A very good morning to you, ladies and gentlemen, and welcome to the annual Scientific Congress of the Sri Lanka College of Specialist Family Physicians 2025. Planetary health meets primary care, an evidence-based practice for a sustainable future. So, before commencing our day as one family, one big Sri Lankan family, let us all rise for the national anthem of Sri Lanka.
Sri Lanka Mata, Abba Sri Lanka, Namo, 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 Namo Mata. Sundara Siri Marini, Surani Adi Sobamaya Lanka. Manya Nalaya Lekamal Palatu Pili Jaya අපහට සැපසී සෙත සදලා ජීවනයේ මාතා පිළිගනු මැන අපවත්තේ පූජා නමෝ නමෝ මාතා අප ශ්‍රී ලංකා නමෝ 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 නමෝ
Thank you very much. Well, the day is about to begin with something very interactive, and it's going to be the dermatology quiz themed test your knowledge conducted by Dr. Sanath Vijayasuriya. Ladies and gentlemen, before we commence the quiz, this session is a Slido presentation where all of you are required to scan the QR code and then select the answers. And the winner will be awarded at the end of the presentation by our quiz compiler. So, ladies and gentlemen, I would like to introduce our quiz master, Dr. Sanath Vijayasuriya, acting consultant family physician at the base hospital Kiribati and specialist general practitioner at Enderamulla. With over 25 years of medical experience, he has worked across multiple specialties before dedicating himself to family medicine. He holds the DFM MD in family medicine and MRCGP International and has pioneered the GP service at Enderamulla since 2005. He has special interest on chronic disease management and prevention with a focus on primary care development. Sir, I cordially invite you to commence the dermatology quiz. Test your knowledge. So, ladies and gentlemen, as I said, this is a Slido presentation quiz. So, do scan the QR code and answer accordingly. Thank you. All right, to motivate you further, the winner will receive a dinner for two from Monarch Imperial, courtesy of the Sri Lanka College of Specialist Family Physicians.
Yeah, I think everybody got this correct. I'm exclusively included this case, this scenario, because we are somewhat reluctant to see the dermatological problems of pregnancy. So this is puff rash. It's a rather the commonest presentation. If we think that it is other vesicular rash, fever rash, and all that, and which is now rarely comes to us, but this is exclusively primary care management. So that's why I put there. It is actually a primary T3 will continue till the end of the delivery and even few weeks. Actually, we have a good dialogue with the patient and make them to understand that it will go on. It is essentially the distribution of the rash, as the pup rash mentioned, pruritic, urticarial, papules and plaques of the pregnancy. So papules and plaques and pruritic urticaria. So those three things are there essentially, not anything else. So you can confidently diagnose pup rash. So when we, it's a distribution of the stria, because later part of the pregnancy, tummy is getting more protuberant, so the stria develops along with the stria, so this rash tend to develop. So another important thing is the pemphigoid gestationalis. So another rash coming at that the latter part of the pregnancy, we have to exclude it. That is actually vesicular bullous disease. It is mainly the another important thing is that umbilical region. So this pup rash is around the stria, along the stria, and pemphigoid is it involves the umbilicus and around surrounding area also. So there's another intrahepatic cholecystitis pregnancy also. We can, in addition to that, where have the detrimental effect of the fetus. In such case, we have to refer. So these are only excoriation, only scratching and excoriation, not the specific rash. Yeah, this actually in our part of the world, humid areas, hot climate. So these young people tend to get the sweat rash. So we sometimes confuse with other rashes. This is a very common thing. This is Miliaria rubrum. It's a blockage of the pores of the sweat glands. So various stages of blockages that can happen. In the most superficial stage, Miliaria crystallina, where you crystal-like sweat beads you can see superficially, and in the middle part, Miliaria rubrum, that is blockage lower epidermis with leakage of the sweat and giving papular eruption, where the periductal inflammation giving rise to red color erythema and scratching. And most importantly, the feel-like scratching, itchy, prickling nature, prickly heat is Miliaria rubrum. When its blockage is more deeper, at the upper dermis, then sweat leaks into dermis, and which cause Miliaria profundum. So it is, even though we feel like giving steroids or whatever the other emollients, so those creams actually they further make the occlusion. It's a hot humid condition, and occlusion of these pores are the main reason for producing Miliaria rubrum. So the mainstay of treatment is cool, avoid excessive heat, humidity, loose lightweight cotton clothes, and air conditioning, cool environment is the main stay of treatment. We can add on to the other calamine lotions, so water-based lotions actually. Other creams and emollients will sometimes worsen it. Antihistamines also you can add, but primary thing is reducing sweat, let them to evaporate easily. Yeah, I specifically put this MCQ question because we often come across this sort of nails in our primary care. So we usually treat with antifungals. Take it as all the skin derangements, we tend to think that it is fungal infection. So we give a lot of high-fi antifungals, which are a lot of expensive drugs, medications, but eventually with no results. So we have to have an idea about differentiating the chronic paronychia versus onychomycosis. So you have to appreciate that the chronic paronychia is a contact dermatitis, irritant contact dermatitis to the detergents. So the skin around the nail is mostly affected by this irritant contact dermatitis. This nail is rather resistant. So you don't see any nail problems initially with the chronic paronychia. Whereas the onychomycosis, the fungus eats the nail. So it goes distally, more distal end and spreading from proximally. Whereas the skin around the nail in the onychomycosis is almost normal because fungus usually stays in the nail underneath that, causing subungual hyperkeratosis, lot of keratin material, lot of cellular material, lot of fungus is underneath and loosening the nail and causing onycholysis, the separation of the nail, whereas the chronic paronychia is tightly adherent to the nail. And the more problem is chronic paronychia is distally. The nail changes also can happen distally, and with time it may come proximally. Nail changes happen more proximally and then come more distally, whereas the onychomycosis is the opposite side, which is commonly seen in primary care. Yeah, this is of course very superficial sort of ulcers, denudation of the skin. You can see it's not deep, so there's something superficial. It is involving the epidermis, superficial part of epidermis. So it is impetigo, where the some toxins from the Staph aureus mostly cause superficial blistering, which is most of the time it is asymptomatic, and it is through the contact. The face is the most common site, spreading among the children. So we have to differentiate it to herpetic gingiostomatitis because it is also superficial blisters and superficial, very superficial ulcers, but it is on both sides of the mouth, inside and outside, because it's a dermatomal distribution and it is very painful. So we have to differentiate it from the herpetic gingiostomatitis and dermatitis, which is atopic dermatitis, probably itchy, scaly, dry skin. In case of dermatitis, which is not seen here in the history also. And the treatment, of course, this is not a serious infection, so treatment is only the antibiotic creams. Yeah, actually we often come across this urticaria, chronic urticaria, but sometimes we used to treat with so many antihistamines, 1 or 2 or several antihistamines, but the guideline, according to the guideline, they say the second generation non-steroidal antihistamines is the first treatment, first step. Either the cetirizine, levocetirizine, loratadine, fexofenadine, you start with that, the efficacy wise more or less same. So the step 2 is, if it is not responding in 2 to 4 weeks or partial responding, you doubling. Still wait for another couple of weeks, and if it's still less response, you triple, you quadruple, and that is a maximum level. So you can go up to 4 times of the standard dose of the antihistamines non-sedating. So this non-sedative antihistamines adding in the night to have a good sleep is not prevent somebody is having the wheals, because it is nothing to do with the sleep, nothing to do with the scratching, it spontaneous comes. This is actually for the atopic dermatitis where people scratch in the night, and to stop scratching you can use Piriton or something in the night in addition, but it's not so with here. And combinations are not evidence based, and H2 antihistamines also, ranitidine, famotidine, cimetidine, also not evidence based. They say that if 4 times you can increase, and after that you have to refer to the dermatologist. Another Montelukast, those things are you can try later on. Actually they are not evidence based, and short course steroids can be given in acute flares. Otherwise it has also no place. Yeah, this actually the explanation of rash is mostly important. It is slightly scaly with erythema and atrophy, and margins are not very clear, asymptomatic, slowly progressive. So it is not. So once you given a MCQ or whatever, just imagine that all the other, what is mentioned here is only things that can be seen in the patient. Everything else you imagine is not there. So mycosis fungoides actually, it's a interesting lesion, even though it is a non-Hodgkin type of non-Hodgkin lymphoma. It has a patch state, decades, and then go into the plaque stage, another decades, and tumor stage. Once it gets into the tumor stage, it is rather slow course, and it can spread to the other areas. And of course, they will die of some other disease because it has a very long course. So primary treatment, the biopsy is actually exactly characteristics. So you can diagnose with the biopsy, but clinically we have to have suspicion because it is not tally with the other answers. And for the vitiligo, it is completely deep pigment, not chalky white. For the tubercular leprosy, so there are no characteristic features in that rash. Yes, this is a sort of neurodermatitis, nodular prurigo. Extremely, once in a way, actually, these patients going from one place to the other, even a dermatology clinic, they take a short course of treatment, not responding to another doctor, going to another primary care doctor. So we have to have a good dialogue. We have to recognize this as nodular prurigo. It is intensely itchy nodules, symmetrically distributed in the body, in the accessible areas, lateral arms, legs, shoulders, chest, the accessible areas. And most characteristically, these dome-shaped nodules are excoriated, broken and crusting. The top ends are broken because too much of excoriation, and there's a itch scratch cycle. It itch initially, then scratch, it further itch, further scratching, further itch. It's like a vicious cycle. It may start as some other rash, like whatever the dermatitis condition, insect bite or drug allergy or whatever, and will go on become a nodular prurigo. And it's fairly resistant, so we have to give these steroids under occlusive cover to make it more absorptive, and we have to give a very strong steroids also. And it's not easily resolving, so we have to have a good conversation with the patient and long-term management. Of course, probably we refer to the dermatologist. It's a shared care management. Yeah, I specifically put this question because the tinea infections, dermatophyte infections are very common. They are coming to the primary care, and there's a blame that the GPs tend to give the steroids because the GPs are sometimes confused with that this tinea infected patient sometimes comes with atypical rashes. So they are not typical with like the tinea, the ringworm shape. So these are actually sometimes there's a very good chance to have an id reaction. Id reaction is an interface dermatitis reaction. That is it's a autosensitization of the that's allergens coming from the dermatophyte allergens, antigens. So they will attack the interface, that is the interface between the epidermis and dermis, which are very good place to get the insults of the autoimmune damage. So hypersensitive reaction to the allergen is the primary skin dermatosis distant from the primary site. So we have to take, so it may look like a contact dermatitis, it may look like another tinea infection, it may look like the formplex, but we have to get the other part of the history. We have to connect the two together and the different appearance. So we know that some GPs and the doctors give both steroid and antifungals because they are confused with that. So we have to be clear that there is something called id reaction, interface dermatitis reaction, which gives so many other rashes. Actually, patients coming with these id reactions rather than the tinea infection. So the GPs, doctors are confused that. So we have to understand it is the primary. We have to look for the primary rash. most likely a tinea infection, or sometimes it may be contact dermatitis some other place, most of the time. So we have to address the primary reaction, look for the primary reaction, address the primary reaction to get the full resolution of that, rather than just treating the reaction. Yeah, there's another important lesion, that's a herpetic Whitlow. So this looks like an infection, bacterial infection. Of course, we confuse it because it's extremely painful, but erythematous, maybe parotid-like lesions underneath that blisters. So we confuse with its bacterial infection. Occasionally, these patients comes. It's very painful. It is secondary inoculation of the HSV 1 or 2. Most importantly, if you try all the other treatment, antibiotics or whatever the treatment, it won't resolve. It doesn't give any relief with painkillers or whatever, and may last 2 to 4 weeks to that patient to suffer unless you detect it early. Because acyclovir reduces the symptoms, duration of the illness, and recurrence if started early. And moreover to that, the surgical intervention, pinching, pricking, or incision and drainage is completely contraindicated because it will quickly make it a secondary infection and bacterial infection, or even the disseminated infections also. Yeah, this is another important and very commonly coming to the primary care, which is called the pitted keratolysis. It's shallow punch-out ulcers on weight-bearing areas of the foot, coiles, erosions, and most of the time it causes very foul smelling. Somebody is having pitted keratolysis, definitely you will understand, you will smell that person, very fishy odor that coming from that socks or that person's foot. So that's a very embarrassing thing unless you diagnose it properly. So you can't give a proper treatment. So it's a bacterial infection actually, usually bilateral, that colonizes in the stratum corneum. So it is promoted by hydrosis, occlusive footwear, humidity, prolonged standing, friction, the predisposing factors, and their proteolytic enzymes, keratin breakdown causing these pits, and it causes sulfur compounds that cause the characteristic odor. So antibiotic is the treatment, antibiotic creams. So first we have to diagnose the condition. It's actually a wart. So there are similar conditions, plantar callus, plantar cones. So this is, as the figure shows, the callus and cones are due to pressure, because this lot of degeneration with age, osteoarthritis, rheumatoid arthritis, diabetic or whatever, will change the anatomy of the foot, and sometimes certain areas are more susceptible to unnecessary pressure, which cause the ischemic sort of thing, and conified layer will be thickened. If it is more diffuse, it form callus, or very focal, it is cone, or this wart is a viral infection of the keratinocytes. So management is that, of course, you can do paring for the callus, and the cone, of course, there is some keratin inside, some keratin particles right inside, which has to be removed by the surgical means. But the wart, we can do paring to expose the depth of the wart, and salicylic acid treatment also, because to kill the virus-laden cells. Yeah, most of you rightly diagnose it. The acne, so when you diagnose the acne, so we have to differentiate, because it's young age, the rosacea is unlikely because there are comedones and nodules, cysts are there. So papules, pustules, and occasional nodules are there. So we have to diagnose it as acne, because of the age and all that also matters. So the severity, we have to categorize the acne, first diagnose and categorize the acne for the treatment. So there's a comedones, whiteheads and blackheads, where there is minimal inflammation. The first stage, that mild acne, and when it comes to moderate, that is actually papules and pustules are there with some inflammation because of the bacterial infection, Corynebacterium, and it will further enlarge with nodulocystic severe acne. So the treatment, mild acne, only the comedones, that is creams, mainly the adapalene. All of the stages we used to treat with adapalene, but starting with adapalene, so you can add on to benzyl peroxide or antibiotics depending on the inflammation, the acne, the mild status. So if it is mostly papulopustular, that is moderate acne, we have to add in addition to the oral antibiotic. We start with oral antibiotic and adapalene. Depending on severity, we have to can add the others, because this girl fits to the moderate acne, so we have to add oral antibiotic also, because inflammation is due to bacterial infection. Severe acne, where the final stage of the inflammation and about to scar. So we start topical treatment as well as and referral to the dermatologist. Okay, thank you.
All right, that was nice, and thank you very much, Dr. Sarath Vijaysurya, for conducting that derma quiz, test your knowledge. And as you could see, we have a clear winner with 7 correct answers out of 12. So, Dr. Naveen Vijayveera, congratulations to you, and can we have you on stage? And I would like to invite our quiz master, Dr. Sarath Vijaysurya, to come on stage to give away the gift. Thank you very much, Dr. Sarath Vijaysurya, and congratulations once again to Dr. Naveen Vijayveera. Moving on, ladies and gentlemen, it is time that we commence our annual academic sessions 2025, and to welcome all of you with great pleasure, I invite Dr. Malkanthi Gallena. Madam, over to you to address.
Respected President, Dr. Priyantha Halambarachi, respected past President, Dr. Lalantha Senaratna, Vice President, Dr. Pradeep Gunawardena, the esteemed council members, and the scientific committee, the distinguished guests, invited speakers, colleagues, and all the medical officers, ladies and gentlemen. I want and a very warm welcome to all of you today. As chair of the scientific session, this is our second scientific session we are going to have today. It's with great honor and privilege that I, as the chair of the Sri Lanka College of Specialist Family Physicians, extend to your heartfelt welcome to our second scientific session. Today marks not just another academic gathering, but a continuation of our collective journey to strengthen family medicine and primary care in Sri Lanka. This scientific session stands as a treatment to the vision and dedication of our college to bring together clinicians, academics, researchers, and policymakers in one forum where ideas are exchanged, knowledge is shared, and collaborations are born. Our role as the specialist family physicians is pivotal. We are at the heart of healthcare system, ensuring that every Sri Lankan receives accessible, comprehensive, and patient-centered first contact care. Over the past year, our college has grown in both stature and responsibility. We have expanded our academic activities, launched initiatives for the continuous professional development, and engaged with national and international partners. These efforts are aligned with our mission to contribute towards universal health coverage by 2030, ensuring that our people benefit from evidence-based, compassionate, and equitable care. This second scientific session brings together a distinguished panel of speakers and a rich program of presentations, discussions, and workshops. I am confident that the knowledge we gain here will inspire us to further raise the standards of family medicine in Sri Lanka and empower us to address the growing challenges of non-communicable diseases, aging populations, and evolving patient needs. I take this opportunity to sincerely thank our organizing committee, our sponsors, our academic partners, and as well as our council, and each of you all are very important, your participation. So your presence today is a proof of your commitment to advancing the discipline of family medicine, not only within our own country, but across region. Ladies and gentlemen, as we commence this scientific session, let us do so with the spirit of learning, collaboration, and service, qualities that define as the specialist family physicians. On behalf of the Sri Lanka College of Specialist Family Physicians, I warmly welcome you once again and wish this session every success. Thank you very much. All the very best.
Right, we're about to commence sessions with token of appreciation, and that is to Dr. Sarath Vijaysurya for conducting this dermatology quiz, and I have great pleasure in inviting Dr. Malkanthi Galhena, our immediate past president, to hand over the token of appreciation to Dr. Sarath Vijaysurya. Thank you, sir, for that elaborative quiz, as you explained the answers as well. And thank you very much, Dr. Malkanthi Galhena. Thank you. Right, we're moving on to Symposium 1, Digital Transformation in Primary Care. And with great pleasure, I would like to introduce the two chairpersons. There is Dr. Malkanthi Galhena, who is a specialist family physician at Base Hospital, Panadura, and she's the chairperson of the scientific committee, as well as the next chairperson is Dr. Udanta Radgamage, is the secretary of the Sri Lanka College of Specialized Family Physicians, and he's a specialist family physician at Base Hospital, Horana. We have planned for 3 sessions, but then the third session of Professor Hiran Amarasekara, due to unavoidable circumstances, sir will be coming at 2:30. So we will be having the first 2 sessions now, and with great pleasure once again, I invite the chairpersons, Dr. Malkanthi Galhena and Dr. Udanta Radgamage, on stage, please.
Today, I'm going to introduce our first speaker. It's my pleasure to introduce Dr. Kumar Mendis for his lecture titled The Doctor-Patient Consultation and Use of Artificial Intelligence in Primary Care. Dr. Kumar Mendis has held senior academic roles in Sri Lanka and Australia, including Professor of Family Medicine at the University of Kelaniya and Sabaragamuwa, and as an Associate Professor at Western Sydney University, where he continues as a Conjoint Associate Professor. He is the first person in Sri Lanka to obtain qualification in medical informatics. He currently contributes his expertise as a clinician and academics to the Department of Community and Family Medicine at University of Moratuwa. A widely published researcher in family medicine, informatics, evidence-based practice, rural health, and obesity. He has also contributed extensively to medical education and digital health leadership. Please join me, Dr. Kumar Mendis, and in warmly welcoming you to the stage.
Good morning to all of you, and thank you very much. I have to thank the college for inviting me and giving me the opportunity to present this. The title of today's talk will be Doctor-Patient Consultation and the Use of Artificial Intelligence. I want to start off, I know your theme is related to the planetary health and primary care. So I think we have to think a little bit about our planet first. So this slide is from a week ago, BBC conducted a session on planetary health. And this slide is directly from the BBC program. So it says, every interaction that you make with the ChatGPT or any other form of large language models I'm sure all of you will do this every day. Every tick on ChatGPT, Google, Gemini, or Microsoft Copilot, or any other large language model will use 1/15 of a teaspoon of pure quality drinking water. You must be wondering how that is. Now, this was given by the person who is the CEO of OpenAI, and the other scientists think that he is far too low on the estimate. They estimate that it is about 2 or 3 times this. And let me explain how this is. Every time you put a query, I want my presentation to be tweaked, or I want this research summarized, you get the computers, huge amount of computers, computer networks that are installed in the USA, UK, and especially the developing countries like Chile, Argentina, Brazil, India. They have these huge computer networks that need to be active, and that generates a lot of heat. For the cooling, they use pure drinking quality water, because seawater cannot be used because it corrodes the cooling pipes. And also, any form of contamination will damage the cooling pipes, and they use drinking quality water. And this BBC was interviewing some people in Chile. They say, please don't come here and install this, because you are dealing with the very precious amount of drinking water that we have. So I hope that you think for a moment before you just click at GPT or other large language models. During this session, I will give 2 definitions of artificial intelligence and consultation, and take every stage of the consultation and try to discuss whether how AI can help this stage of the consultation. Artificial intelligence is a field of computer science that involves developing intelligent machines that perform tasks that typically require human intelligence, such as understanding natural language, recognizing images, making predictions, and decision making. Doctor-patient consultation, that's nothing new, but I would like to reiterate the essential unit of medical practice is the occasion when, in the intimacy of the consultation room, a person who is ill or believes him or herself to be ill seeks the advice of a doctor whom he trusts. This is the consultation, and all else in the practice of medicine derives from it. Okay, so from the time of Hippocrates, 400 BC, the consultation was between 2 people, the doctor and the patient. Then late 1980s or early 1990s, there was an intruder. A computer was placed in the consultation room when they introduced electronic medical records. It formed a huge problems. In UK, the practitioners, the doctors who introduced the EMR had to face problems because the patients left their practices. Why? Because the doctors were more interested in the EMR than the patient. So they had a problem because they were not used to dealing with a computer and a patient. So in England, especially, they left practices whom the doctors had introduced the EMR and went to other practices. So this was a start, and now what have we got? Now we have two human beings and another AI being. Why am I telling AI being? Artificial intelligence being, I say this because it is as intelligent and maybe more intelligent than the human being. So we have three beings now in the consultation room. Now we get on to the consultation is intricately linked to the digital world. There's no escaping of this. To obtain benefits of AI, data, we need data. AI is hungry for data, digital data, not pieces of paper. It wants data in electronic format, and the EMR will be the main tool that if we want to get benefits of AI, you have to use one of these electronic medical records. So I will go history, examination, investigations, diagnosis and treatment and see what benefits each stage can have, from AI we can have. Take in the history. You are looking at an advertisement from the US. These are now, at this moment, commercial packages, AI-backed commercial packages. This package is known as patient notes. What does it do? You start the consultation and go on talking to the patients, not worrying anything about taking notes. Right? Before you install this program and tell the program once, what format do you want your history? SOAP format maybe. Subjective, objective. I want not more than 50 words in each. I want the diagnosis, everything. You tick the boxes once, and then the application, AI-backed application is working. You have the camera, and you do your consultation without worrying about taking notes, because then you have your full concentration focus on the patient. At the end, you will have the notes written into your electronic medical records in the format that you asked. So history, we have no problem. What about physical examination? This is Professor Abraham Agassi from the Stanford University, USA. One of the leading, Harvard and Stanford are the two main universities that is ranked world number 1 and 2, I think. And he says, he gave a very nice TED talk. Please listen to this. You just Google and say, Doctor's Touch, Abraham Agassi, you will get the, please listen after you go home. He says, if somebody, a patient comes to our, now Stanford is in Boston, USA. He says, if some person comes without a leg to our hospitals, unless we do a CT or MRI or a PET scan, they won't believe that you don't have a leg. So examination, clinical examination is so much neglected. Everything is investigations, scan, MRI. He says, this has to stop, and he introduced a very nice document, Stanford 25. he lists the 25 essential physical examinations that a medical graduate has to master before graduation. Just 25 only. At least that much you have, because the physical touch is so important, and patients accept this. They want us to examine. You must have heard patients saying, Dr. Mava ande dalat examine karo. So don't think that by ordering the latest PET scan or the whole body scan that the patient will be satisfied. No, they want the personal touch of a doctor. This is a human to human. No AI being can intervene and examine a patient. Remember that very clearly when you, and especially a family physician, right? We care for the whole person. So our human touch will be extremely important. Now the third is investigations. How does investigations help? This is the area hugely supported by AI for the clinicians, right? Just for example, I have taken mammography. You order a mammography, and we order a lot of investigations, imaging, ultrasound scans, CT, MRI, PET, and we have to wait for the report from the radiologist, right? Now I just want to present evidence for the mammography. Now this is a meta-analysis, right, of 13 studies, including more than 150,000 patients who underwent the mammography, and the results were given by the radiologists and also the AI, which was trained on mammographies to detect any abnormalities, right? And what happened? The accuracy of the diagnosis is exceeded 93%. So it was a very good screening test for mammography, not to bother the radiologists. Just think of a imaging study that you ordered at night. Patient is waiting, the radiologist is not there, right? You have to wait till morning for the image report. And the other thing is, radiologists are human beings, and going through a CT scan of 5-6 CT MRIs in one evening, what happens? They get tired. When you are tired, you get more prone to doing errors. So there's no such thing. AI does not sleep. AI is available 24 hours and it does not get tired. So your report, we are looking at an era when we order a CT or MRI, with the report comes the AI generated report on this. It is maybe 5 to 10 years away, if the radiologist allows us. What we have discussed is how AI can help us out in the history, examination, and investigations. We'll see the next step, diagnosis. I have showed this slide on many occasions, and I apologize to the people who have seen this. In year 2000, a seriously ill child was admitted to a London emergency care unit. The diagnosis was missed, incorrect. The child was in the ICU for nearly 2 weeks, and this picture is the day that she was discharged. And it was This slide is the picture shows the day of Isabel's discharge from the London hospital. It was a rare complication of a common disease, chickenpox. The doctors completely missed it. And the child's father was a bank and a computer expert. As usual, he did not sue the hospital. Normally that's the way in other countries, they put a claim, and he designed an AI-assisted chatbot, very primitive chatbot, so that when the doctors entered the symptoms of a patient, a differential diagnosis came out without missing anything. So 2000, this was the first AI-assisted chatbot, and they used this extensively at the NHS UK. Now, we have this commercial, there are various commercial AI-assisted applications to generate a differential diagnostic list when you put in your symptoms and the demographics. So that, I mean, human brain has a limited capacity. It may miss certain things, rare diseases, but this does not. Some of you will say, no problem. We get the ChatGPT, put in the symptoms, it will give us the diagnosis, no problem. You don't need that kind of expensive things. Don't do it. Why do I say that don't do it? Because ChatGPT is a large language model not specifically trained in medicine. It's they have gathered data from all available websites, documents. It is not specifically trained for medicine. If you want this type of thing, use MedPalm, that is the Google tool, but the only problem is it is not free. Quality things are not given free. You have to pay it, right? So this is the level of AI that helps the diagnosis. We just go one part beyond the diagnosis, predictive medicine. How many of you believe in horoscopes or have a horoscope? I'm sure. Yes. Please. At the birth, you are not in control. You will have a horoscope made. Birth time, right? So you will have a horoscope. Can we have a horoscope for our patients? What do you say? Yes, we can. Get ECG. Why do I say this? What can an ECG predict? Heart problems, irregularities. I have forgotten most of how to read ECG, except a myocardial infarction now, right? So now this is all evidence-based. AI applications have been trained to look at an ECG without any age or anything and detect, and they can say this is 40-year-old female just by looking at the ECG. Whether the patient is anemic, the level of hemoglobin, whether they have kidney disease, whether the patient is suffering from hyperthyroidism, diabetes or pre-diabetes. Just the ECG. Can you think how far the AI applications have trained? And then, if you want a little bit more complicated thing, give them a retinal scan. Just a retinal scan. And I don't know how many of you will like to know whether you are the probabilities of Alzheimer's disease. I don't want. So I won't do any retinal scans, right, at my age. Right? So hyperlipidemia, Parkinson's disease, heart calcium score by looking at the retina. So this I have been validated. All this I have given with Lancet, Nature. This has been validated, but not commercially available now, for now. The last topic will be treatment. We have heard a lot about personalized treatment. Everything is personalized now. Let me give a very simple example of hypertension. We treat hypertension every day. This is not a very complicated diagnosis, and so this research got 42,000 patients from several GPs and randomly divided into two. Right? So all GPs had the electronic medical record with their patient. This was done in the US, right? And one half, the GP decided, right, looking at the problem list, all other applications, what is the antihypertensive that I will begin, right? And the other half, GP's computers were installed with a AI application that was trained to treat hypertension. Remember, training AI application needs huge amount of data. So 100,000 or 1 million patient records that was with hypertension. They are trained on that kind of huge amounts of data. And this application was installed, and the application also prescribed out of the same drug, not medical drugs. There were 10 to 15 drugs available for hypertension. They also. Then after 6 months, they saw that the AI-assisted prescription, the patients with the AI-assisted prescription had 70% larger drop in the blood pressure than the doctor. So this is treatment. So we have gone through the history, examination, investigations, diagnosis as treatment, and at the end, I want to share and end my presentation with the author, Eric Topol, who is a cardiologist and a genetist, old-fashioned cardiologist and a genetist, and a leading expert in artificial intelligence. He has written a very nice book, Deep Medicine. He says the greatest opportunity offered by AI is not reducing errors or workloads or even curing cancer. It is the opportunity to restore the precious and time-honored connection and trust, the human touch between patients and doctors. He is the man who is expert in AI. So what would be the ultimate aim of using artificial intelligence in medicine? Increase the time doctors talk to their patient, establishing the doctor-patient relationship that is fast dwindling. Isn't this what the doctor-patient consultation is all about? Thank you.
Thank you very much, sir, for delivering the really informative the lecture, because our medical professionals have been updated into a new era with innovation. It's artificial intelligence. Thank you very much, sir. You are kindly requested to remain, to be seated here, because till this first symposium is over. Thank you, sir.
It is my great pleasure to introduce Mr. Ananda Galapatti, a medical anthropologist and one of Sri Lanka's leading figure in mental health and psychosocial support. For nearly 3 decades, he has strengthened support system for vulnerable communities in Sri Lanka and internationally, with his contribution recognized by the Raman Magsaysay Award and the Ashoka Fellowship. He currently serves as co-director of MHPSSNet, director of strategy at the Good Practice Group, and is a commissioner on the Lancet Commission on Racism and Child Health. His recent work explores the intersection of digital transformation, mental health, and global health equity, particularly the responsible use of AI to expand access to care. Today he will speak on the need of a roadmap for digital health in Sri Lanka, opportunities and challenges ahead. Over to you, Mr. Ananda Galapathy.
Thank you very much. First, to the college for having me today, and particularly to Professor Kumara Mendes, who made the connection and invited me here in the first place. I'm going to be speaking briefly on a topic that actually I don't know that much about. So that's a short disclaimer. The reason is that something's happened to the. But basically, my background is in mental health and psychosocial support. Kind of the foundations are in the context of crisis settings. But in Sri Lanka, of course, since we've had crises for so many decades, it also interfaces with regular care in a number of different settings. So I have a broad spectrum of work. I'm not a clinician, but very often the work I've been involved with has been about trying to deal with large-scale problems with very limited or unevenly distributed resources. I have been working on some digital solutions from as long ago as the tsunami, when we used blogs to give information that people could download to provide support. And I run an online platform, as mentioned. And more locally, we've been using it for practitioner knowledge exchange. I myself am a user of well-being tools, as many of you may be, and even remote therapeutic services. And of course, since COVID-19 and the economic crisis, we have had to adapt to more online modes of also doing training, experiments in e-learning, but also in social emotional learning interventions for children. So I'm not a digital mental health expert. I have been thrown into this area by chance, but also necessity. And most recently, I helped to convene, I supported the convening of a digital mental health roundtable, and I'm currently involved in following up on this. It is a steep learning curve, and so I'm going to be speaking to you from a point of view as a learner myself, trying to provide an overview of my evolving understanding of the field and trying to place this in the context of Sri Lanka. At the global level, there is a sense that there is a digital mental health revolution, or rather digital mental health is going to revolutionize our field. With the COVID-19 pandemic, we saw, and all of you must have also participated in, this sort of surge in telehealth, online consultations, even something, it's Zoom platforms or dedicated platforms. And this was the only way that very often people could access services. And we adapted very quickly, sometimes without adequate training or structures or infrastructure. But this growth, though remarkable, was limited by clinician availability, and also that growth has, since the end of COVID, particularly globally, has been contracting and is estimated to be less than 50% of the peak in 2024 that it was at the height of the pandemic. But simultaneously, in relation to mental health promotion and care, we see the emergence of 3 key technology platforms that really can have a transformative impact. Those are smartphones, virtual reality, and as Mr. Kumar spoke about, generative artificial intelligence, which has really burst onto the scene since the end of late November 2022. Let me talk about the smartphone because it's such an important kind of device in all of our lives. I'm sure no one would deny that anymore. There are over 10,000 mental health applications available on smartphone. But they're not always the same 10,000. A lot of these are on the App Store and then they will disappear. So it's not a stable population. And the majority, or at least very many of these, are marketed not as health devices or health interventions, but as tools, but as well-being ones. And this may be for regulatory and kind of liability reasons. But this is one of the most extensively researched sectors in digital mental health. One of the things just to note is that very few of those 10,000 have scientific literature to support them. And similarly, many of those interventions that are actually scientifically tested and evaluated actually necessarily wind up in the marketplace. So you have to remember that the research and the marketplace are not the same thing. There's some overlap, but not much. Right? And one of the concerns about the literature is that it does not necessarily reflect all the negative or adverse events that are as a consequence of using these or associated with using them. Although in some trials there have been rates indicated as high as 20%. So that's a real concern, and that is one of the reasons why in a lot of clinical practice people, there has been a reluctance to include and integrate these apps into clinical because of concerns around safety. There are, however, some areas where we do have some evidence, and I'll move to that. So one is that there are areas where you have strong evidence, multiple meta-analyses supporting, for example, in the area of depression and anxiety. There are small but significant effects in reducing depression and generalized anxiety symptoms from one of the larger meta-analyses. And interestingly, you would note that a lot of the research has been done since in the last few years. Right? And other meta-analyses have found evidence for reductions in social anxiety, post-traumatic stress, acrophobia, and obsessive-compulsive symptoms. And it's found that CBT principle-based apps with some kind of chatbot interactive technology have been the most effective, but also that human augmentation increases the effect sizes of those app interventions. So that's something to keep in mind, and that's something that recurs throughout the literature. Of course, the biggest area, the largest number of apps are these well-being apps. And those the ones that have been tested do show subjective quality of life improvements, mindful awareness improvements, because they're largely about helping people develop psychological capabilities in relation to day-to-day life challenges. So subjective well-being is improved, social functioning, self-esteem. But this is the thing, only 2% of the publicly available, roughly, well-being apps have published supportive scientific evidence. So basically, don't download the things that you find in the App Store unless you cross-reference them against what's published. In other areas, and it's important that it doesn't work equally well for all forms of it has not been demonstrated to work equally well for all forms of types of mental health conditions. For bipolar disorder, for example, there isn't any evidence of reduced symptom severity, but there is, and even in some cases, there's some notion that mood monitoring apps may increase depressive episodes in certain cases. Again, in relation to schizophrenia, there are some positive effects, but it's mixed, not across all studies. And again, the human involvement seems to be critical in enabling those positive. So there is a need in certain conditions, definitely, for more professional oversight. In relation to eating disorders and substance use disorders, both of which are problems for which people often do not have access to support and often find it difficult to receive professional support. There's actually very limited research, and those apps that are out there lack research support, and sometimes are just on face value seem to be poor quality. So we've got these apps, we've got thousands of them. But do people use them? Right? So one of the other concerns is that in terms of when they a review that looked at usage of apps by people who had consented to participate in studies around the apps found that as many as 50% sometimes did not even download the app, even though they consented to the study. And another study that was looking at real-world usage of 93 popular apps, mental health apps, showed that there was a 4% median daily open rate and only a 3% 30-day retention rate. So people are downloading these sometimes, but then they don't use them. So, in terms of improving population, even if these work, improving population mental health is going to be challenging if we don't address the issues of low engagement. And the reasons why people may not engage is around ease of use, so not well designed. There may be privacy concerns around sharing things that are to do with your own mental health and personal problems. There may be doubts about the benefits. Digital literacy, people are not familiar with how to use these, and a lack of personalization. And you can imagine that some of these concerns in the context of Sri Lanka would be perhaps even more strong. Even though there are there's also work done that is showing that it is possible to counter these challenges through kind of approaches that involve things like building trust, co-designing with the end users, ensuring that there's human support to kind of help people use it. And I think one of the things that was very interesting for me was this idea of a just-in-time intervention. The notion that people are not always susceptible to using a digital mental health tool, but there may be moments in their journey of dealing with their mental health problem where they might be open to it. And how do we make this available at that point? Let me move on to virtual reality. Now, virtual reality has some very promising possibilities that traditional mental health interventions don't have, because traditional mental health interventions take place in clinical settings where you're in a consultation room, or you're in a setting where the life circumstances that you're dealing with, or perhaps the situation that you are finding challenging, may not be accessible. You can only do it through recall or through imaginal exposure, for example, in the case of anxiety disorders. And what a virtual reality kind of intervention does is it allows you to experience it as if you were in that context, right? And there is very positive evidence around virtual reality CBT for anxiety, with some mixed diversity in the effect sizes. For PTSD, it's as good as traditional CBT. For social skills training, including for ADHD, there's limited research, but also some positive and some not so positive findings, but it's too small to be able to tell. And in terms of relaxation environments, it's equal or superior to non-virtual relaxation, right? But it's more resource efficient, but that's also in a particular kind of context. So the thing is that these have been tested in trials, but there are very few applications on the market, and one of the challenges is around the difficulty with scaling this to a wider audience, the wider population. There's, there are challenges in the cost of the devices, the training required to utilize them, and to make these accessible, especially in low resource settings. So there's something to watch out for, but certainly is not having the same sort of boom, for example, that smartphone-based applications have. And now we come to the topic of our age. I think, as Professor Mendis mentioned, generative AI has this sort of has taken over the popular imagination and our professional imaginations also around what we can do that was never possible before. So until 2022, 96% of chatbots across all healthcare were driven by decision tree-like logic. That is, it's a rule-based something that is predetermined by the designers, and not really artificial intelligence. So you had predefined scripts and decision trees with which the patient or client would interact, and this offered a really safe, controlled environment. It was it's already determined by the people designing so nothing unpredictable could happen. But the challenge was that people don't necessarily like interacting with that. They want to be able to speak freely. These models couldn't process free text inputs and couldn't really maintain conversations as well. Following the public launch of ChatGPT in 2023, that was 3.5, there has been this surge of interest and kind of a hope for what it could offer for mental health. And overall, there has been a huge shift in terms of kind of people trying to implement machine learning powered models, especially based on large language models. And the reason for that is that they are able to generate human-like responses. They manage diverse outputs, which could be text, voice, and image. They can respond empathetically, and they can also really personalize their interactions based on these kind of long-term conversations that are carried through, right? There isn't much research on this, and one of the reasons for this is that, I'm not sure if it was on this, but I'll have to get to that in a second. But the little research that is there basically can be summarized like this. In terms of prevention, there's very low risk associated with what we have right now. It offers personalized psychoeducation and can, especially when it's trained on high quality resources. For relapse or onset detection, it's pretty good at doing risk prediction on certain areas like suicidal ideation or other crises. For diagnosis, it can, as described in the previous presentation, it can sometimes match a clinician's ability to assess mental health conditions, especially in relation to depression. And in terms of treatment optimization, it can support clinicians in decision making, often using patient-specific data. In crisis intervention, it has been demonstrated to provide elements of crisis counseling, but there are still risks of harm, and we'll get to that shortly. And in terms of support to psychotherapy, it's been used to look at past sessions and give feedback to clinicians around how they might change the way that they offer therapy and counseling. Now, the problem with LLM-powered chatbots is that we have a lack of real evidence. A lot of the larger models lack transparency in data. We can't explain how those models exactly work because that's proprietary. And there are also no standardized evaluation models, whether it's on looking at ethical behavior or it's looking at efficiency. And as Professor Mendes mentioned, they're trained on essentially the internet and a whole lot of other data sources, but including social media, and therefore they learn not only the good but also the bad, right? So they reflect the stigma that exists out there in the world around mental health and some of the biases. And one must remember that the internet is not value-free. It is not every community, every culture is not equally represented there. And so there's a cultural bias also in the worldview that an LLM develops because of whose experiences, language, and perceptions are reflected in the current training source data. Right? And third is a really important point, and I think this is one that might be relevant to your interactions with patients as well, who are trying to understand how, what kind of intelligent being or not AI is. Because it sounds like a human, it interacts like a human, it may even sometimes pretend to be a human. But currently still there are challenges around sometimes complex social reasoning, and essentially I may be corrected on this, but what my current understanding is the best way to do a lay explanation of what a LLM does is it's a super high-powered autocomplete function, right? It uses all the data it has to generate a probabilistic response. It doesn't actually know things. It knows what is known, and delivers a response based on that. And therefore, there are certain limitations for what it can do in terms of dealing with novelty, which is why we get errors. And for example, I used, as an exercise, I used a particular AI LLM to synthesize some of the data I wanted for this presentation. But I had to go back and check it and rewrite whole sections because it got it wrong. It didn't understand how things, right? So some of it might have been my poor prompting, but it was also about how it didn't recognize things in the same way that a human being does. Similarly, there's this issue of companionship versus care, right? So LLM-powered chatbots can feel like your friend or your supporter, or in some cases you'll see people feel like it might be their therapist. But, and that itself has often therapy. People experience benefits of that. But there is still a level of unpredictability and possible negative outcomes, and these instances of harm, some of which have been shared quite internationally, cause considerable concern. Right? Clinical documentation was dealt with in the previous. However, there's also, interestingly, especially in relation to mental health concern, there are some of the question of how well regulated some of these applications are because they're mushrooming. And there was just last week I read an article that was an expose of a particular therapeutic note-taking function, application, which then said, we will use your data to train our AI and maybe other AI products, right? So suddenly your data is not personal. You don't know where it's going and who's going to be using it, right? And of course, training is another area where I think there's a lot of investment right now. Companies like Google, which are not going into the therapeutic area, are looking at using AI to train clinicians and non-clinicians. There are a number of barriers and facilitators. I'm just mindful of the time, but essentially a lot of them at the practitioner and the service level are around readiness, negative perceptions, poor literacy, lack of confidence, concerns about privacy, resistance to change. These are the reasons why people are not taking this on, right? And at the service level, sometimes the tool comes, but it doesn't fit in with the way in which we work or our institutions work. So there's a need to kind of align these, and one of the ways of doing that is to design collaboratively with the population, whether it's a service user population or it's a service provider population that you're building for, and to build for interoperability. And at the systems level, of course, we need frameworks to enable, but also to regulate these, and also to enable kind of financing of these, especially where there's a big upfront cost. I'm just going to quickly switch to talk about Sri Lanka. And Sri Lanka, this is my drawing of how the Sri Lankan mental health field has kind of developed over time. And you see that big bump around the time of the tsunami, because we've evolved a lot in response to crises. And the tsunami was the last time we had a major change in the kind of the approach to mental health in this country. We suddenly expanded through a policy that focused on building community level mental health capacity. We increased coverage enormously. But yet we have a very limited and quite broadly dispersed mental health and psychosocial support system in this country, across the state, across civil society and non-profits, and the private sector. These are not to scale. But in Sri Lanka, what we've also seen is that we've had these crises that have one on top of the other. Recovering from a conflict, then we have, after that, a small lull, we start recovering, then we have COVID, then we have the economic crisis and political unrest and so on. And these mean that vulnerable populations and the general population are put under repeated stressors, which increase the propensity to develop clinical and non-clinical mental health problems. So we have problems related to human resources, availability and quality, not enough people and not always well trained. We have big issues with stigma and mental health literacy, right? People don't know that it's a mental health issue and they don't want to talk about it, and they think that we have socioeconomic barriers to access, we have a diversity of needs, and we also have a combination of daily life stressors, chronic problems, and crisis events. But in Sri Lanka, we do have some, I'm going to take a couple more minutes if you don't mind, Chair. We do have things that happen. None of my slides are endorsements of anything that's up there, including my own work. But to say that these illustrate the fact that Sri Lanka does have a digital mental health space. So our 1926 these are helplines, which are also increasingly adding chat functions, because those seem to be more acceptable to many of the populations that they're trying to reach, right? And ones that are, and also for dealing with online issues. In the corner you have a service called Pratya that does that. We see every day, like a couple of days ago I found a new platform for online therapy. Some of them you can find out who the people are and what their credentials are. Some, it's nameless, faceless. There's no sense of what people are getting. So there's clearly some issues around kind of transparency and accountability. You have spaces for certain populations like LGBTQIA plus populations that may find it harder to meet in person or find community. You have online spaces that are being facilitated. You have platforms like Dialogue who are looking at ways in which they can create digital assistants, and Dialogue is about to launch an AI-powered version of this. We also have social emotional learning. Above is the well-known Tilly app, and below is a prototype that I've been working on that is for early adolescents. We have e-learning for practitioners, for service providers, and this is an example I'd like to share, which is a still failed, I still have hope for it, a platform for everyday support for everyday problems for people, right? And we have still a very, very small kind of literature based in Sri Lanka. But interestingly, some of you may have read this in the Daily Mirror, I think it was last Wednesday or Tuesday, Wednesday. This is the graphic from an article which was talking about how in Sri Lanka today, young people and adults are also using some of these AI, LLM chatbots as companions and as people to turn to for their support. So clearly we have issues. On the 23rd of June this year, there was a roundtable convened by the Office of the Prime Minister and also the E-Mental Health International Collaborative, which brought together a number of experts, including Professor Mendes and others, to explore what the state of play is in Sri Lanka and how medical technologies can address some of our challenges. And we had some input from the Prime Minister herself, who has a history of working in the field of mental health, and then also some of the international collaborators. And they looked at kind of opportunities, barriers, and gains and risks related to this, to mental health, digital mental health design, but also AI technology. And I think what was very interesting for us was that the PM's speech gave us 4 guiding principles. She talked about accessibility and equity. She talked about quality and safety. She talked about participation and co-creation. And she talked about integration and sustainability, right? And those, I think, were quite appropriate in the context of what we've heard in terms of my summary of the roundtable participants. I'm not going to go into all of these, but they identified many of the issues that prop up in the literature, but from a Sri Lankan point of view, around infrastructure, around AI application, strengths and challenges, around data privacy and regulation, around culture. For example, what people use is sometimes not English, Sinhala, or Tamil, but a mixture of those, right? How does the chatbot work with that? But there was definitely a sense that there is something that we have to do around utilizing this, because it has the potential to really transform in terms of cost, in terms of reach, in terms of accessibility, in terms of privacy and anonymity and scalability mental health services that we do not yet have in this country. In terms of the road ahead, this is my last slide, we do need urgently leadership from government, from professional bodies, from academia and from the industry to set up a roadmap for digital mental health to guide us in terms of policy, regulatory frameworks, pilot initiatives, evidence-based development and financing. And we need some platforms where we can come together to learn and innovate, to teach each other and also to incubate things. And I would say the most urgent things that we need to register all those apps, and we need to create guidelines and codes of conduct and establish a cross-disciplinary working group on digital mental health. I will leave it there. Thank you so much for your time.
Thank you very much for your very much informative and the timely the speech delivered to the empower our medical professionals. I would like to stay with us for the token of receive the token of appreciations.
Thank you very much, chairpersons, and I invite the chairpersons, Dr. Malkanti Galhen and Dr. Udantarat Gamage, to give away the tokens of appreciation to Mr. Professor Kumara Mendis and Mr. Ananda Galapatti. Thank you, and next we have a lecture on early recognition and assessment of organ damage by Dr. Malkanti Galena. And to read the citation, I have great pleasure in inviting Dr. Shalini Senaratge, specialist in family medicine, senior lecturer in family medicine, Faculty of Medicine, University of Kelaniya. Madam.
Good morning. The next session will be on early recognition and assessment of organ damage by Dr. Malkanti Galhena. It's my greatest pleasure to introduce the speaker, Dr. Malkanti Galhena. Dr. Galhena graduated with her MBBS from the University of Peradeniya and built a distinguished career in family medicine, holding clinical, academic, and leadership roles across Sri Lanka. Currently, she serves as a consultant family physician at the base hospital Panadura. As a key contributor to national policy, she serves on the Primary Care Development Advisory Committee, Directorate of Healthcare Quality and Safety, and World Bank's Primary Care System Strengthening Project. She is the immediate past president of the Sri Lanka College of Specialist Family Physicians, and her role continues as a teacher, trainer, examiner, and a researcher. In recognition of her outstanding contribution, she was recently awarded the prestigious honorary fellowship of the Sri Lanka College of Specialist Family Physicians. Please join me in warmly welcoming Dr. Malkanti Galhena.
Good morning, everyone. So, regarding it's the evidence-based management of diabetes and hypertension in primary care with recognition, assessment and management of CVD risk and end organ damage is the topic today, where I hope that it will be most the beneficial lecture to you all, because being the first contact care providers, I know how important this is to become evidence-based to the care provider. In case of the NCDs, so globally, so over 83% of all deaths are due to NCDs, according to WHO. And of all NCD deaths, 73% are now in low and middle income countries. So we also belong to that category. NCDs, particularly the hypertension and diabetes mellitus are leading causes of morbidity and mortality in Sri Lanka similar as to the globe. So cardiovascular disease is the leading cause of death as well. So silent progression, end organ damage occurs before symptoms appear. So these two diseases are silently progressive diseases where the patients are not aware about. So this is just to mention about the global burden for you all to know, as also same that and the comparison to the Sri Lankan burden as well. That is the real burden to our country in lining with the global burden as well. So hence the CVD risk assessment and the screening for end organ damage are crucial at diagnosis, follow-up care to align with provision of best evidence-based patient management at primary care level to ensure the patient safety. So in case of the diabetes and hypertension, I know all of you all are treating these two diseases. So because of that, patient presentations you must know. So it's a symptomatic patients with no diagnosis. So the asymptomatic patients with no diagnosis, asymptomatic patients with confirmed diagnosis, complicated patients with symptoms, and the previously healthy people need screening are the presentations to the first contact care in these two diseases. So what is the role of family physician? So family physician should be always updated with the evidence-based knowledge, and you have to need your skills in the consultation in order to manage the patient safely to prevent them going into the organ damage and the CVD events. So that is the target of our management. So as the role of family physician, we are positioned at first contact care level. So because of the whole responsibility comes to our shoulders. So knowing your patients, you are very much competent to provide this care because you know your patients, families, communities in depth. And as well as integrate, you can integrate the risk assessment and screening into visits and bridge the gap between guideline and practices, identify the challenges and opportunities are your main roles. So what are the challenges that we have being Sri Lankan the first contact care provider? Limited diagnosis in rural areas, overcrowded OPDs, adherence, the barriers. And the opportunities that we are having is digital health calculators, not all places, but many of the places now it's coming up, and the task, the shifting to nurses and the national registries. So knowledge into action is the one that we have to practice with our patients. So confirmation of diagnosis, that should be guideline based confirmation, and the number 2 is very important, detecting of underlying end organ damage whenever you are getting the so-called previous patients, the different types of presentations. And the detection of CVD risk, it's very important. So not just getting the diagnosis and just giving the treatment is not the evidence-based management. So because of that, you have to always attend to the detection of underlying end organ damage and the detection of the CVD risk, and then decide most appropriate evidence-based management considering following factors. The factors are: consider comorbidities, that is very important, and consider evidences of. To summarize that till it comes on into the screen, I am going to tell you, that is, I told you the confirmation of the diagnosis, which should be guideline based, detection of underlying end organ damage and detection of CVD risk, and accordingly after giving the priority for these above 3, that is the detection of underlying end organ damage, detection of CVD risk then confirm the diagnosis according to the guideline-based confirmation. Then the number 4 is decide most appropriate evidence-based management considering following important factors. What are the important factors? Consider comorbidities, consider evidences of end organ damage, consider the CVD risk, and most appropriate pharmacotherapy which aligns with evidence of CVD risk and the positive findings with organ damage. No, just it's not a just start the tablet for the patient according to the pharmacotherapy according to the diabetes and the hypertension. You should follow these 4 steps where I am going to tell you how to do it. I hope that you all are doing this as well, but to strengthen your knowledge, I will support you. And then you have to go to the most appropriate pharmacotherapy aligned with these evidences of CVD risk and the positive findings, and the guideline based follow-up care is another important factor. Then we are going to make the decision in this particularly these 2 diseases, not only for 2 but here this is the cycle for patient-centered management in diabetes and hypertension in primary care. So when the patient comes, you are going to evaluate the patient's characteristic, that's by taking history and the examination. So you will come into the possible, the tentative diagnosis after exclusion of the differential diagnosis. Now then evaluate the evaluation of the specific risk factors which are very important and which are the ones that come into play here. That's what I am going to talk about you here. So this the stage of the evaluation is very, very important for being the primary care physician to provide the treatment for these 2 diseases. Then you create the management plan is another important thing. So as we all are doing, agree on the management plan, implementation and ongoing monitoring and review and revise is the goals of care. So when we come to the further elaboration, why end organ damage matters. So that is for early intervention, identify the silent complications before they become clinically obvious. And another reason is risk stratification, that is the changes the patient's category from uncomplicated hypertension or diabetes to high risk, influencing treatment targets and intensity. And another important thing is it helps to take the decisions on treatment. That is the guides escalation of therapy, that is example adding renoprotective agents, the stricter blood pressure and diabetes mellitus targets through pharmacotherapy. Then the prognosis also it's a very important, and through the end organ damage screening, end organ damage will give you the presence of organ damage like heart, kidney, eye, brain, that is the end organ, significantly increases the morbidity and mortality. So end organ damage and the CVD risk assessment are crucial. So we are going to talk about this end organ damage first. So what are the target organs? These are the target organs, right? And then we'll go to this is the pictorial representation that I have given you in order to know. These are the end organs that you have to focus about the prevention of those damage. So detection of underlying end organ damage. So in case of detection, how do we detect? So we are in a practicing environment. I know most of you all are the after hours GP practitioners and the full-time as well as the Ministry of Health doctors who are providing primary care at some point. So because of that, so the end organs are kidney, then retina, then the cardiovascular system in the sense heart, and then the neurological and the peripheral, the neurological damage, then early detection to prevent disability. So these are this is, the detection of end organ damage that we are focusing. So in case of renal, urine ACR, not to go just before the thinking about just serum creatinine, the urine ACR, albumin creatinine ratio is the landmark of, at the very initial stage that kidney is going to be affected. So because of that, without forgetting the ACR, you have to start with ACR, EGFR, and the finally serum creatinine, because in case of serum creatinine, the damage is, the advanced to some stages. So you have to stick to this guideline management to renal assessment, and the serum electrolytes and the urine full report, because in both diseases, hypertension, urine full report will help to diagnose the proteinuria, where we are thinking about the secondary causes. But in diabetes, the patients may be having proteinuria as well as the asymptomatic bacteriuria, which will be complicate the renal the function. So because of that, both disease, this is very important. Retinal, in the perspective of retinal damage, the fundoscopy, renal photography, cardiac ECG, exercise ECG, echocardiogram, and even you have to think of, the CT, coronary angiogram in case of stable angina, with the patient can't, do the exercise ECG, that is the gold standard. So, but it needs a referral at the correct time. So, neurological and the peripheral, the nerves, the foot checks, and the ankle brachial pressure index. Early detection and prevention, early detection will prevent the disability. So because of that, it's very important for you all to think about, not to think about the start, the detection of end organ damage at the very first contact care. So practical workflow for the evidence-based management, this is I just mentioned you, so that, in case of complication that you are hoping to detect, in case of kidney, ACR, as well as, the increased ACR and the CKD. So guideline target are these: blood pressure should be less than this, and the target HbA1c, because elderly people need the little higher HbA1c compared to the younger people. So because of that, target HbA1c, the first line therapy, this is regarding the end organ damage, right? ACE inhibitors or ARB, but the first line is ACE inhibitors, not the ARB. Keep that in mind. And additional measures like, in case of the proteinuria, SGLT2 inhibitors, even without diabetes, for hypertension also you can add, and as well as, the nephrology referral is a must, but nephrology referral, at primary care till 30, the EGFR up to 30 we can manage with the evidence-based manner, but the problem is in case of, the patient needs, the sudden the decrease of the EGFR due to some infection or some other cases, we have to have a plan in advance with the nephrologist to initiate the dialysis and the further treatment. So because of that, it's bit of early referral, and the follow-up management by you is, really recommended. Right? Even though we can manage the patient according to the international guidelines up to 30 EGFR. Then the heart, LVH, heart failure and coronary artery disease are the one, the organ damage that we can detect. Here again I have mentioned about this is in summary, I have given you ACE and the beta blockers comes into play. So you have to check the patient's heart rate. If the patient is diagnosed with these diseases, then you have to, with the hypertension or diabetes, or with both, right, then you have to add the beta blockers according to the patient's pulse rate, because if the pulse is low, you have to start a minimum dose. Because of the the bradycardia, that patient can go into without any notice. And the treatment, the first line is this: additional measures are statin, antiplatelets if CVD, established CVD risk is there. Statins in the sense, I will come into that, we have to assess the CVD risk of the patient, but if here in case of LVH, heart failure and coronary artery disease are already established cardiovascular disease, where we have to start without the assessing the CVD risk. it's a very high risk that the patient is having because of the established disease. So your statin therapy, it's a must here, right? CVD risk is very high that you can start with 40 to 80 milligram statins, right, daily basis. And the antiplatelets also, it's very essential because established cardiovascular diseases are there. Not for any patient who didn't have any established CVD, the diseases like this, we are not going to give you the antiplatelets or aspirin or clopidogrel. So the brain, TIA and stroke, here the targets I have told you. Again, it should be in the blood pressure is the target is this, HbA1c 6.5 or less is the one for younger, but in adults you can go ahead to the 7.5 depending on the patient, the status of the health. And it's the very important to again maintain the blood pressure in hypertensive and the diabetes control, and they are accordingly we have to go, even for the nerves also same. So this is the simple thing for you all to understand, but why we need to understand that, get that, and we have to manipulate the pharmacotherapy, the pharmacotherapy as well as the referral. So at the correct the time according to the evidences. And why CVD risk assessment matters, I told you CVD risk assessment and the end organ damage is the crucial thing. So without doing that we are not going to start the treatment. So we can, if the patient is having, because with the time that need to take the investigation, then ask the patient to at the earliest possibility with the investigation within 2 weeks time to adjust the medication that you have introduced. Depending on the CVD risk, you have to you may have to change. So that is why it's very essential. So risk factors, the risk factors like in case of CVD risk assessment, it's very important because risk factors act synergistically to accelerate the vascular injury. In both disease, vascular injury is the problem to the end organs, like the epithelial damage due to 2 reasons. In diabetes, it's hyperglycemia. In case of the high blood pressure, it's due to the blood pressure which gives the thickening and the sclerosis of the endothelium. But the final long term the process, but the final the outcome is same, they're creating some organ ischemia. So aim is the CVD risk assessment aims to prevent heart attacks, strokes and the premature deaths. And the 10-year risk of stratification is the guide and therapy for this CVD risk assessment to be done through the 10-year CVD risk assessment and the stratification guide, which are the tools are QRisk3, the newest one, and WHO charts that we use in our clinics in Sri Lanka, WHO charts mostly, but telephone you can use the QRisk3 the tool as well to identify the particular patient's CVD risk. Definitely you have to, it comes as the less than 10% and 10 to 20% and more than it's 20 to 30, I will tell you. This is the the chart. It's very easy. If you train your the nurses with the reports, relevant reports which needs to assess this, they will do that. So, but you have to train them very well. Then otherwise the time will be, and your even medical officer can do very quickly. This is available at the online WHO the website, as well as it can be downloaded and keep on your table to assess this. It's a must for you all to do. So QRisk is from your app, you can get it. So there the percentages are, they have highlighted here about you can see how they are, the colors wise they have provided the green, the yellow, orange and the red and the dark, the brick red. So accordingly you have to identify easily, you can identify what the risk of patient is, whether it's 10%, below 10% or in 2020 or within the range of 20 to 40 or over 40. Like that, its categorization is very simple, and our medical team is doing it very well, and we don't treat our patients, without assessing this organ damage and the CVD risk assessment. So we are going to talk about now CVD risk assessment. So management of increased CVD risk, provided that you are got the CVD risk below the 10% or it's above 40% or whatever is. It tells that the patient risk about getting CVD events in next 10 years time. So it's very, very crucial for you all to identify that among diabetic or hypertension or both, and then start the treatment. Okay, and start the treatment you can do, but in 2 weeks time at least get the patient back and adjust the treatment according to this results of the CVD risk and the end organ damage. So optimization, so how do you manage this increased CVD risk? That is more than 10, right? Optimization with oral hypoglycemics and antihypertensives according to the best evidences. I'm talking about both diseases. And encouragement for correction of gaps in lifestyle and behavior, and stratify the statin strength and add for the patient management. So according to the CVD risk, the risk groups comes as low to moderate risk groups, right? And it will nicely mention about that chart, so nothing to worry about that, right? And the high risk, it's and the very high risk groups. So these are the 10, less than 10 is not at a risk. So because of that, it's not a big thing, but provided that even though the 10-year CVD risk is less than 10, the patient is having other diseases like the comorbidities like the hypothyroidism, strong family history of the strokes or the early premature CVD deaths, then you have to take as the high risk patients, right? So just forget about, you can't forget about if the CVD risk calculation by the chart comes as 10%, that is why the history is important. So you have to always consider history and examination findings and then these assessments. That is how it comes into play. So the risk groups in the sense, I have here summarized for you all to go understand this easily. The target LDL-C is the one we are targeting regarding to the reduction of the CVD events, and the statin intensity, it's very important to select. So the typical starting doses that we have mentioned here. So low moderate risk, less than 100, and the moderate in the statin therapy, it's a moderate dose, it's to the low moderate risk group, right? And the typical starting doses of statins are 10 to 20 milligram, and the Rosua 5 to 10, Rosua statin 5 to 10. The high risk, if the LDL, the target should be less than 70. So to achieve that, you have to statin, the intensity is the high intensity statins, that is atorvastatin 40 to 80, and in case of rosuvastatin 20 milligram the daily dose. Very high risk, again if the LDL target is less than 55 and the statin intensity is high or maximum, that is atorvastatin 80, rosuvastatin 20 to 40. So this is how you have to identify and optimize the management, even though you have started initial therapy for either to diabetes or hypertension or both, but you have to get the patient back and assess it, and then optimize the pharmacotherapy in the rational way. So guidance-based clinical targets, I have again here mentioned about the general NCD patients. It should be, these are the values that they have according to the guidelines they have the mention. So this is in detail that I have provided for you all to go through that. Because in case of blood pressure it should be 140/90, but the high risk CVD patient with the target organ damage, we have to think about the control in the blood pressure below 130/80, and as well as in HbA1c. So it should be 6.5% or less. But in case of the target organ damage, either target organ damage or CVD risk or both, in such case, we have to think about the individualized, because it should be again the 6.5, but the problem is in such a case we have to tailor-made according to the patient, because elderly people need, the frailty people need little bit higher, the target. So in case of atorvastatin, again it's, usually I know that diabetes, the guideline says that is to start with 20, right? After you, generally the diabetic patients, you have to start with 20, but in case of, because already the diabetes is, the condition where the CVD risk is becoming, the more. So because of that, they advise us to go with 20, not with 10 for diabetes. And as well as, in case of the positive TOD or high CVD risk, again you have to go to the high intensity statins, that is 40 to 80, regardless of baseline, the cholesterol values. And the other thing is renal protection, the monitor UNE, urine ACR and EGFR annually. But if the patient is having some more other comorbidities, you can, the expedite the process of screening, not annually, even in 6 months, and it's depending on the patient. So regarding ACI, ARB is mandatory in case of, the TOD and high CVD risk. That is, not only that, if albumin or urea or proteinuria, this is the SGLT2 inhibitors, empagliflozin or dapagliflozin is indicated as, the preference for the proteinuria management either in hypertension or diabetes. Without having diabetes as well, you have to add that to reduce arrest the proteinuria progression. Then if you go to the ophthalmology, that is the renal screening every 1 to 2 years for NCD patients, but annual retinal screening, urgent referral, the sight-threatening disease is a must, but even though it comes as annually, you have to expedite according to the TOD and the high CVD risk. Right? Then we'll go to the foot care. Annual foot examination is the recommended guideline management, but in such a case, each visit, if neuropathy or ulcer risk is there, so you have to, not only that, you have to send the patient for the specialized foot care assessment team with vascular surgeons as well, because we are here to provide, the prevention, not to wait till the complication comes and then send the patient. So the antiplatelets, not for primary prevention, that's very important. So better not to, prescribe any, the antiplatelets, aspirin and clopidogrel. So because it's not being the indicator, because these are very much the high side effects drugs, the patient may get very much the higher risk of getting without indication. So better please not to prescribe that for any patient without the established CVD disease. But yes, it's the very well indicated for the established CVD, like I told you, the heart issues, even strokes, TIA, or any other evidences for the cardiovascular disease. It's the lifelong aspirin or clopidogrel, right? Not both, right? And the lifestyle, smoking cessation, diet, weight, exercise, same, but with the strict, the adherence and monitoring need to be very important, because get the patient in monthly basis to assess the weight and the hip waist circumference ratio with monthly monitoring of weight and this thing, then the patient might be enter into the practice. So guideline based protocol management has been introduced in Sri Lanka for primary care physicians. So because of that, it's available at the Ministry of Health and the primary care institutions. This will provide very much the tailor-made, the target, the control with the CVD risk and the identified organ damage. It's very easy for you to go ahead with the protocol, what next and what next in optimization of the therapy. Then furthermore, management of pre-diabetes and the mask hypertension is the challenges that primary care physicians are having, where most of the time it's being neglected, so they will be ended up with organ damage. So because of that, you have to be always think about whether this, whenever patient come, whether this patient is the pre-diabetes and whether this patient is having masked hypertension where the blood pressure is low at the clinic, but whenever you are going to investigate with organ damage, the patient is having such, particularly the ECG shows that example common hypertensive heart disease, that is the end organ damage, where you need to confirm the blood pressure again with ambulatory BP monitoring. Like that you have to, these two situations are very much the crucial. So thank you very much. Hope that you have got some idea about the organ damage assessment and the CVD risk assessment in order to provide the best evidence-based care in primary care for your patients. And call to action, I'm telling you, prevent stroke, save kidneys, preserve eyesight, preserve sexual health, prevent the amputation and the help to prolong life for our patients. Family physicians must lead this transformation. Thank you very much.
Thank you, Dr. Malkanthi Galhena, for that detailed and insightful talk on end organ damage screening and as well as cardiovascular risk assessment. Actually, it is very important for a comprehensive care for our patients. And you are kindly requested to remain here with me. And do you have any questions from the audience for Dr. Galhena? Please do accept the token of appreciation on behalf of the college.
Ladies and gentlemen, that was a lecture on early recognition and assessment of organ damage, and that was conducted by Dr. Malkanthi Galhena. And to give away the token of appreciation, I invite Dr. Shalini Senaratge, the moderator of this session. Thank you very much, Dr. Shalini Senaratge and Dr. Malkanthi Galhena. And ladies and gentlemen, we are breaking for tea, and please note that the tea break will be for 15 minutes. And there's a raffle draw conducted by John Keel's Properties. Do take part in that, as well as do visit the stalls at the other side of this hall. Thank you very much, and do return by 10:35. Thank you. Welcome back, ladies and gentlemen, and we are about to move on with the next event, that is the distribution of our own newsletter of the Sri Lanka College of Specialist Family Physicians, the Anchor, the Primary Care Newsletter, Volume 3, Issue 1 for the month of September 2025. And with great pleasure, I invite our editors, Professor Kumara Mendis and Professor Arulanandam, to hand over this copy to our president, Dr. Priyantha Halambarachi. And also I would like to mention that this newsletter has been designed by our very own Dr. Sindhu Pasaniviratna, acting consultant, family physician based hospital, Chilab. So once again, inviting the editors, Professor Kumara Mendis and Professor K. Arulanandam, to hand over the copy to the president of the college, Dr. Priyantha Halambarachi. And also, I kindly request all of you, when there's a break, please collect the copy of your newsletter from the college counter just outside this hall premises. Hi, also we would like to have Dr. Sindhu Pasaniviratna also to join together with the editors, Professor Kumara Mendis and Professor K. Arulanandam. So once again, it is time that we hand over this Volume 3, Issue 1 of the Anchor to the President of the College, Dr. Priyantha Halambarachi, by the editors, Professor Kumara Mendis and Professor K. Arulanandam, and also we have our designer, Dr. Sindhu Pasaniviratna as well. And ladies and gentlemen, your copy of this newsletter is available at the college desk just outside this hall. All right, moving on to Symposium 2, that is Planetary Health Meets Primary Care. And with great pleasure, I introduce the chairpersons, Professor Kumara Mendis, Senior Professor of Family Medicine and first person in Sri Lanka to obtain a qualification in Medical Informatics. He is the visiting consultant at Community and Family Medicine Department, University of Moratuwa. And also the chairperson of this session, Symposium, is Professor K. Arulanandam, Professor in Family Medicine in Department of Primary Healthcare, Faculty of Healthcare Sciences, Eastern University, Sri Lanka. So the chairperson, I cordially invite you to commence the next symposium, number 2, Planetary Health Meets Primary Care.
Hope you all are back again. And with a cup of coffee or tea, you are very attentive, I think, now. We start off Symposium 2 on Planetary Health Meets Primary Care. The topic will be Environment Impact on Respiratory Health and Disease Management by Dr. Niranjan Dasanayake.
Okay, good morning. I am so glad to introduce our speaker today. It is to my privilege to introduce Dr. Niranjan Dasanayake, consultant pulmonologist at the Teaching Hospital and District SES Clinic, Kalathura. Dr. Dasanayake holds MD Medicine, MRCGP UK, FCCP Sri Lanka, FRCP London, and FCCP USA. He is the immediate past president of Sri Lanka College of Pulmonologists, chairs its Critical Care Assembly, and serves on several national health advisory committees, including those for tuberculosis, communicable diseases, and tobacco and alcohol control. He maintains an active research portfolio in tuberculosis, non-tuberculosis mycobacteria, respiratory infections, and floral diseases, and has been recognized internationally as a young physician leader by the National Academy of Sciences in Sri Lanka and the Inter-Academy Medical Panel, LAMP, as well as through his association with the European Respiratory Society. Please join me in warmly welcoming Dr. Niranjan Dasanayake to make this speech, please. Environmental Impact on Respiratory Health and Disease Management. Thank you.
Good morning, ladies and gentlemen. Thank you, Chairperson, sir, for that kind introduction. And it's indeed a privilege to be here. And I would like to thank the President, the Council, especially Dr. Malkadi Galhenage, as well as Dr. Tharindra, for coordinating my speech. And I actually had the liberty of taking the picture from your flyer as the initiation for my talk. Now, this is a beautiful picture depicting how a living being interacts with the environment. So each and every living being has an interaction with the environment. There is mainly some physical interaction from the air we breathe, the food we take, as well as the temperature changes. And at the same time, we are interacting always with the environment psychologically as well as socially. And each and every aspect of these interactions has implications to our well-being, to our health, and as the topic suggests, to our respiratory health as well. So my task today is to highlight and outline how each and every component is affected, and it is affecting the respiratory health in a living being. So as a pulmonologist, our main thing is the lung. I think it's the center of our universe as a pulmonologist. And we, as living beings, breathe about 20,000 times per day. And we take in about 10,000 liters of air. We inhale and exhale. And when you look at the lung, for example, the skin, even though it is directly in contact with the environment, it is about 1.5 square meters in adult, but the lung has 300 million alveoli, and it has a surface area of almost a tennis court. And this lung, the alveoli and the airways, are constantly exposed to the environment. Even though we know that the air that we breathe is not of good quality, we can't hold our breath. We can not eat for about 3 weeks, not drink for about 3 days, but we can't not breathe even for more than 40 seconds, maximum 2 minutes. So we have to constantly breathe, and our lung is in constant interaction with the environment that we surrounding us. And this environment, we have a very intricate airway system where it is dividing into 23 subsegments and ending at the alveoli. And at each step, because we are exposed and through the process of evolution, we have mechanisms to prevent ourselves from getting damaged. So basically, we have the cough reflex, the physical reflexes that are there to prevent our respiratory system from getting damaged. But at the same time, we have a beautiful system of epithelial lining, which is lined by mucus-producing cells and ciliary epithelia, which helps to push out various substances which are unwanted from the lung into the outside. And at the same time, we have a beautiful, intricate immune system which has secretory IgA, and at the same time, we have a good innate immune system. You know, we are always marshaled by the alveolar and the pulmonary macrophages, as well as we are marshaled by the T cells, as well as other cellular components, which keeps us healthy. So that is one of the most important aspects. Even at the alveoli, with this thin membrane, we have pulmonary alveolar macrophages, which keeps us without any significant disease processes. But unfortunately, even with these systems in place, our lung can be damaged in three main ways. One thing is the inhalation substance can directly damage the lung tissue, which is because of the toxic nature of that substance per se. The second thing is it can actually create an immune reaction or activate an immune reaction that can cause damage and can cause inflammation and damage. And the third thing is if this particle is a microorganism, be it a virus, bacteria or other organism, it can come into the system and cause diseases to ourselves. Now, when we look at the alveolus, the structure, our damage doesn't end at the alveolus, because when you look at the alveolar structure, we can beautifully see that it is a very, very thin membrane. It is only a cell, two cells separating the the bloodstream from the lung, unlike the skin. So whatever happens in the lung has a propensity to have a systemic involvement as well. So you can imagine, and you will now agree, that lung is the center of a human or living being's universe. Right. But, when we think about how air affects us, one of the best examples that can be historically taken is from the London fog, where it was shown that the air pollution, at that time London was a center of industrial revolution, and they had a huge amount of coal factories going on, and these contributed immensely to the air pollution in London, and as a result, we knew a phenomenon called London fog, and it has shown that retrospective analysis has shown that a significant proportion of increasing amount of infection and exacerbations of lung diseases has happened in that aspect. So it opened our eyes to the effects of air pollution. But even though we know that we have this air pollution can cause problems, unfortunately 9 out of 10 people worldwide, we breathe bad air, unhealthy air. And especially 80% of the urban residents breathe air that is far below the WHO standards. So we are in a huge conundrum. And as a result, it is calculated that 7 million people prematurely die because of air pollution only. That means about 1/3 of the population of Sri Lanka dies prematurely in the world, according to WHO statistics, because of air pollution only, both indoor and outdoor. And as we correctly identified, because the lung is the major part, but it can affect the cardiovascular systems. It increases the strokes, it increases the heart diseases as well. So we will see how it happens when my talk evolves. But when we concentrate on the lung only, unfortunately, it causes asthma, COPD, interstitial lung disease. It exacerbates asthma, COPD, and other diseases. It predisposes patients to pneumonia, as we saw during the London fog. And unfortunately, in the long term, it can predispose to a person to develop lung cancer. And we have in Sri Lanka, unfortunately, even though our female populations is about, smoking population is really, really low in Sri Lanka, but we have a high proportion of female cancers, lung cancers in Sri Lanka, mainly adenocarcinomas in Sri Lanka, maybe because of the exposures and other exposures that are having in the household contacts. So, is there a way of measuring the quality of air that we inhale? We actually cannot measure everything. So, we have identified some important aspects or some important components that are causing significant health consequences. One such is what we call the particulate matter. We call it PM, which I will be going into detail. Ozone is another important aspect, because ozone, we know it is a protective layer in the air earth, but when it is there, when you have some electrical appliances, some even vehicles produce ozone, and then sulfur dioxide and nitrous oxide are the things that we usually measure to monitor the air quality, and it is measured by the air quality index. So what is today morning's Sri Lankan figure? Today is, I think, the 21st. So fortunately, most of us are in the green, because probably it is a Sunday today, less amount of vehicles. Unfortunately, we don't have the Colombo values, but Puttlam has a moderately severe poor air quality index, but that is not the picture throughout the year. And you can see the US Embassy data showing a hugely unhealthy data in a working day in Colombo, as well as Kandy and other urban areas have this problem. So, you have seen that one of the factors that we measure is the particulate matter. What is basically the particulate matter? So particulate matter is, now this is actually a human hair, and this is what we call a particulate matter. So that is that is a particle which is less than 10 nanometers or 10 nanometers or more. So we call it PM. PM10 is particulate matter 10, right? So this particulate matter can be a dust, a pollen, a carbon particle, even a water vapor, right? Whatever it is, it can cause significant issues. And when the particle matter is 10, it usually affects the upper airways, because it deposits in the upper airways and the pharynx. But when it is 2.5 in diameter, it can reach up to the bronchoalveolar system. And when it is 0.01, it can even reach through the alveoli, it can go through the alveoli, and it can affect the cardiovascular system. And it has shown that especially people who are in heavy traffic for a long time, in a daily basis, are having a predisposition to have heart attacks as well as strokes than compared to other people, because of the particulate matter 0.1, right? So I think it is very important to note that. So when we look at the particulate matter 10, it is usually causing nasopharyngeal problems, mainly upper rhinitis as well as some degree of asthma. When the particulate matter is 2.45, it affects the bronchoalveolar system, it causes asthma exacerbations, it causes lower respiratory tract infections, it predisposed to lung cancer as well. When it is 0.1, where the size is minimum, but the reactivity, you can see it is very, very high. And even though the size is small, the reactivity is high, and it can affect the pulmonary alveolar vascular component, and it can cause lung cancer, interstitial lung disease from the lung, but it can cause strokes and ischemic heart disease in the heart and the other organs as well. Nitrous oxide is a low, it's a low molecular substance which usually doesn't dissolve very well, hence it can reach the bronchoalveolar segment. Sulfur dioxide is very soluble, hence it reaches the nasopharynx only, it cannot go beyond that, but it is a trigger for asthma as well as reduced nasal functions. And ozone, it is hugely reactive, and it can actually travel into the lower respiratory tract system and cause exacerbations of asthma and infection as well. So these are proven studies that have shown that. So when we look at particulate matter specifically, because I want to highlight this aspect, because it's a new concept, what it does is that when the particulate matter reaches the epithelial system, it activates the alveolar macrophages. So usually alveolar macrophages are protective mechanisms. It tries to engulf the organism and destroy it. But these particulate matter cannot be destroyed, hence it reactivates the reactive oxygenation species in the alveolar macrophage, and it disrupts the normal regulation, and it can cause inflammation because the secretion of unwanted substance into the epithelium. The second important thing is it can actually alarm the epithelial system. So epithelium in our body has what we call alarmin systems. So alarmins are interleukin 33, interleukin 25, and thymic stromal lipoprotein, TSLP. So when an epithelial is damaged, these substances are secreted, and these are secreted because of the particulate matter, like an infection, and then it creates a condition where innate immune system is activated, lymphoid cell is activated, and you can get an allergic type reaction in this patient. And the other important thing is it can be engulfed by the dendritic cells, and it can activate the T cell, hence the adaptive immune system also plays a role in this patient. And this is a further diagram, because I think there are postgraduates here. I think it's very important to understand this. So there will be inflammation. There are various cytokines, interleukin 8, granulocyte colony stimulating factor, interleukin 1b, and there will be a lot of oxidative stress in this region, as well as these NLRP, inflammasome is interleukin 18 and interleukin 1b, which actually activates a cascade of inflammatory processes in the epithelial surfaces. And the other important aspect is it deranges the epithelial barrier and the permeability, hence predisposing patients for increasing amount of infection, and at the same time, it further reduces the mucociliary abnormality, function of the lung, hence it causes a dysfunction of the mucociliary aspect. So hence you can understand how these components can affect increasing of respiratory disease burden as well as respiratory infections in this patient. Other than that, it creates a beautiful, another important aspect. We are now into the microbiome, and it is now said that we are controlled by not our brain, but our gut. So we are talking about the gut microbiome, and we have actually a lung microbiome, which actually protects us, and this air pollution can cause significant changes in the microbiome of the lung as well. Hence predispose the patients to respiratory illnesses, respiratory infections, and further damages in the body, right? So in summary, when we look at the air, how we interact with what we breathe, basically we have various sources of pollution, and it can be organizing gases, volatile organizing substances, or ozone, and there will be modulating factors. It might depend on the concentration, where it is deposited, and the duration of exposure might matter, and these effects might be modulated further by other co-exposures like allergens, fungal spores, and metals. And then in a normal person it might not be affected, but in a patient who is having a genetic predisposition, a pre-existing lung disease. So that is why in certain air quality levels, normal persons will not have symptoms, but a person who is having asthma will have exacerbations. So like that, childhood exposure and everything will cause these physiological consequences, right? Increased lower respiratory tract infection, hypersensitivity, IgE or IgG metered hypersensitivity, inflammation, as well as various types of infections and lung function decline as well. But the story doesn't end there. It doesn't only affect the person, it affects a generation of people, air pollution. So this pregnant mother who is exposed to particulate matter, nitrous oxide, volatile organic compounds, and metals will transmit these substances to the fetus, and this fetus will have changes in utero. It will have redox signaling abnormalities, inflammatory responses in the fetus. There will be chromatin remodeling, altered nucleosome positioning, and the most important thing is there will be transcriptional abnormalities in this patient, causing abnormal inflammatory genes to be transcripted. Hence the fetus, while in utero, because of the mother's exposure, will have a chronic inflammatory state in utero. Fortunately, our female colleagues are not smoking, but unfortunately they are exposed to other substances causing this fetal damage, which I will be going into a little bit of detail. But other than the fetus, we actually cause permanent changes in the genetic system by affecting the epigenetic structures of the chromosomes as well. Hence, this fetus, while in utero, is changed, so even their children will have abnormalities in the future generations as well. So this is basically what the air pollution causes, right? And this is a beautiful thing, what we call the getonomics, the genes, the environment, as well as the time. There will be the genome, and depending on the genome, the exposure, there will be low growth weight, there will be prematurity, there will be increasing amount of infections, and then these children are exposed to sometimes smoking. Fortunately, smoking is less, but I will talk about another important aspect, that is vaping. And I'm happy that Dr. Kumar Mendes is here. We did an article on vaping in the SLMA newsletter, and unfortunately, this is a menace in Sri Lanka, even though it is not here. As family physicians, you will get hold of these small things, which are called vaping devices, and unfortunately, children are taking into vaping, as well as females, our female colleagues. They think that it is not harmful, but it is harmful, especially when you think that the lung develops until the age of 20, and in a normal person, young adult, you will have the maximum 100% by the age of 20 to 23. But in these patients who have a genetically damaged lung, genetic predisposition, exposure to the uncontrolled asthma, exposure to firewood, exposure to other substances, will have a poor lung to start with, at around 60%. And these patients are prone to get further respiratory illnesses when they are adults, and they have a very poor outcome, right? So these are some important aspects of vaping, and this is an acute complication of vaping. We call it EVALI, e-cigarette vaping associated acute lung injury. In 2019 itself, there were about almost 2,800 deaths in USA alone due to vaping. Hence, vaping is not safe. It is a substance that damages the lung, especially in the growing ages. Another important aspect is indoor air pollution. Probably we can't do anything about outdoor air pollution unless we work as a group, but indoor air pollution, there are a lot of things that we can do. As family physicians, you can advise our patients to how to improve the indoor environment, because unfortunately, because of indoor air pollution only, we have about 3 million deaths, and unfortunately, majority of them are children, because these children are exposed to indoor air pollution. You can remember when we were children, we were there with our attammas, in the cooking stove, and we were looked after by them. But unfortunately, this is one of the important things that we have to think about. In Sri Lanka only, there's about 18,000 attributable deaths due to indoor air pollution alone, right? And the reason is that one of the major reasons is that cooking is done by firewood, especially in certain areas of the country, and some of them cannot afford. But sometimes, even if they can afford, what I say is sometimes it's very easy to get the males quitting cigarette smoking, but it's very difficult to get a female quitting firewood use, maybe due to social and other factors as well. Right? This affects patients, and you can see that 24-hour mean PM10 level is very, very high when you use indoor air cooking. So it is very important that we ask our patients, especially when the patient comes with a respiratory problem, even in a child, even in a young pregnant mother, even in an adult, the first question that we should ask is, what is their fuel? What is the thing that you are using, and whether the indoor air pollution is there or not in the house. There are enough studies to show that in Sri Lankan context that this is the case, right? And other thing is, in our rooms, there is everything. We have all the pettagamas there. It is damp, and you can see a lot of fungi and mold. These are the allergens that we have. We keep all our, clothes inside our rooms. And when we remove our clothes, even this shirt, there will be cells, and in these cells, there will be dust mites and other organisms that are growing. And we know that in Sri Lankan context, dust mite excreta is one of the major allergens that are causing this problem. However you treat your asthma, however you treat your allergic rhinitis, if you don't address this and advise the patient, they will have recurrent symptoms. What we will do is we'll increase Seroflow 250 to 500, 500 to 2 puff BD, but the patient will not improve unless we address this issue thoroughly. Final 1 or 2 slides. I want to talk about the psychological environment, because we are talking about the environmental impact. So we, are living beings, so we have 2 reactions, fight or flight, or digest, procreate, and rest. So parasympathetic and sympathetic. But it is really important to have a very good sympathetic nervous system or activity so that we can actually prevent unnecessary things from happening acutely. If, for example, a cobra comes here, our sympathetic system should be activated, definitely. But if it is permanently activated, then there will be damage than benefits. So in a constant world that we are living in, we are interacting and we are under tremendous stress in a daily basis. And this causes significant problem in the respiratory system, what we call the dysfunctional breathing, which is the inefficient breathing pattern. Usually, we all have undergone this, I'm sure, right? We have all undergone this. So without underlying disease. But sometimes when you have asthma, pain and deconditioning because you have not worked for some time, you can have this dysfunctional breathing. But one of the major important aspects is stress. How you identify it, as you will feel breathless, not enough air, there will be rapid erratic breathing, and there will be sighing, a lot of sighing. And, we have all undergone this, and I think you can relate to this. And sometimes we are diagnosing these patients as asthma. These patients might have underlying asthma as well, but increasing the inhaler might not work for these patients. But we have to identify the dysfunctional breathing and do the needful. Because one of the major reason is physiological stress and anxiety, unfortunately, especially in our middle-aged ladies who have to have, even though we say housewives, they actually do more work than a person who is going to a job, I think. Especially if you are working, you are doing triple the time of duties in a house. And this causes a lot of anxiety, and it is very common in middle-aged ladies who comes to us. So you want to take a test if you want to, you can just breathe from your nose for one minute, and then after that you can breath hold, and if you can breath hold for more than 25 seconds, probably you don't have dysfunctional breathing. This is called the BOLT test. This is a very crude test. You can do it anytime. But we have a scientific method which is called the Nejiman questionnaire. More than 19 marks will give you a diagnosis of dysfunctional breathing. But another important scientific way of doing it is what we call cardiopulmonary exercise testing, where you will have a disproportionate respiratory rate when you compare the carbon dioxide level. So they start breathing rapidly, disproportionate to the carbon dioxide level, right? So it is important to note that this is not the amount of oxygen that you supply, right? But you have to use the air that we take in to the maximum effect. So putting into practice, breathing through the nose, that's the most important. Breathing light, breathing slow, breathing deep, and sometimes dynamic breath holding. So this is actually, we have been taught in the Eastern culture for a long time. In the Anapanasati Bhavana, in the yoga methods, right, that we do, it is there actually. In our methods, we have it. We have not used it, we have forgotten it, but I think as professionals, even if we start practicing it ourselves, it will make a huge difference. And hopefully, if we can tell the patients who are having dysfunctional breathing after identifying, it will make a huge difference. So it causes a huge importance, and you can see that the changes that can do by having a simple breathing mechanism in even athletes, elite athletes. So you can imagine how it happens. So ladies and gentlemen, I have taken about 2 minutes more, sorry for that. And basically, I think I will end my talk here. So I would like to end like this. We all are living beings. We are interacting with our environment in various ways, in physical, sociological, as well as psychological ways. And each and every component will affect us as a human being, as a living being. And how to manipulate it and will help us to manage ourselves as well as our patients to the maximum levels, rather than leaving them at the mercy of the nature. So thank you very much for providing me this opportunity, and I would be happy to answer any questions if there are. Thank you.
Thank you, Dr. Niranjan, for that very informative lecture. And I think we have a few minutes for any questions. Any questions from the audience?
Get together and do what we call a breathe well, mechanism. And I think the consultant family physicians, because you are with the patients, that we can, hopefully we can develop a mechanism where we can make our patients breathe well. So simple mechanisms which will help these people breathe well.
Thank you very much for that very informative lecture, presentation actually. And we would like to have a workshop with your college, and we'll work together.
Yeah, I think we have to, because probably, family physicians and because primary care, I think, is the way forwards, and we have to have a lot of interaction between ourselves, and that's the reason that we, I didn't have any hesitation in accepting Dr. Malkanti's invitation, as I think we have to work together, and hopefully, especially regarding this breathing well, most of us are unaware. And during this even talk, I learned a lot as well, going through them. So we might be able to develop certain mechanisms using our Eastern cultural methods, so that we can, whether it is Buddhism, Hinduism, anything, but we can use that in developing this mechanism. Hopefully we'll be able to do that, yes.
Thank you.
More question to enlighten the participation. So how can you, what advices can you tell all the family physicians to prevent these the respiratory problems, thinking about the planetary health? Yeah. So early detection, what are the advices that you are going to give to the audience?
Thank you very much for that question. I think the proper respiratory health starts at the time of conception in the mother. Maybe before the mother, because mother's health is the most important thing in having a proper respiratory health in the child. So being family physicians, I think you are exposed from the teenage girls, because they come to you for various types of treatment. So that is the time I think we should start advising them about proper lung health, because proper lung health will give rise to proper lung health in a child, a girl child, will give rise to a good population of children who are having good lung health. And fortunately, as I said, our female population is not smoking, but there is a huge pressure by the tobacco companies to get the female population into smoking, and we have to withstand that pressure. You have seen the films recently, even Rani, right? If you look at the number of duration of, I respect the artists' independence, but when you look at it, there is an overexposure of various, not only that film, lot of things. And if you look at the teledramas, there are a lot of things. So I think family physicians are very close to the patients, close to the children, and they will listen to us because they are close to us. So it's important to instill these values. Especially, fortunately, our male population is now having less amount of smoking. It's about 20% now, fortunately. But we are worried about the female population being smoking. So that is one intervention that we have to do. The second intervention is indoor air pollution. Because these children, especially our girl children, will be mothers. They will be looking after houses. So having good, clean environments of cooking, that is the most important thing. And the second thing is keeping their rooms tidy. You don't have to have big rooms, but in that room, if you can keep away these unnecessary, even if you look at our rooms, it's like that. So if you can keep away these untidy things, keep the room very clean, I think these small things will go a long way in advising them. And especially when the patient comes to us with a respiratory illness, rather than thinking about treating this patient, we have to treat the patient, but we have to manage this patient as a whole. So the environment, other than any other organ, heart failure, probably environment plays a little less. But when you talk about respiratory system, the environment plays a major, major role. So unless you address the environmental abnormalities, however you treat these patients properly, they will not improve and they will come back to us. As well as the psychological aspects should be thought about, especially you can imagine a 40-year-old mother with 3 children who is looking after a house, having tremendous pressure when he's having asthma, and you have to manage everything, and definitely she will be under psychological stress. So if we don't identify that psychological part and the dysfunctional breathing together with the asthma component, and if we don't manage this in a concomitant way, the outcomes might not be very good, and they will go to other people to get treatment, native treatment, and they might destroy their lives as well. So we have a lot to do, and hopefully this will be a good opening for that. Thank you. Right.
Thank you, Dr. Niranjan.
Thank you.
Well, ladies and gentlemen, that was Dr. Niranjan Disanayaka, consultant pulmonologist, teaching hospital and district chest clinic, Kalutara. And ladies, I invite our chairpersons, Professor Kumara Mendis and Professor K. Arulanandam, to hand over the token of appreciation and the certificate to Dr. Niranjan Disanayake. Thank you, sir. Thank you very much. And moving on to the next symposium. Next session is actually an online session by Dr. Aruni Veerakon. I have the chairpersons to take over the proceedings.
So the next topic will be Obesity Beyond Lifestyle by Dr. Aruni Veerakon, MBBS, Diploma in Venereology, Diploma in Family Medicine, MD in Family Medicine, MRCGP International, and Consultant Family Physician. Currently working as a general practitioner in Australia. It is my pleasure to introduce Dr. Aruni De Silva, a distinguished family physician, family medicine specialist, and family physician, and one of my colleagues at the University of Kelaniya, Faculty of Medicine, Ragama. Dr. De Silva graduated with MBBS from University of Colombo and went on to earn a diploma in venereology and family medicine. She achieved her MRCGP International and later completed her MD in family medicine, which included overseas training at King's University, UK. In recognition of her expertise, she was also awarded the FRACGP by the Australian College of General Practitioners. She has served as a senior lecturer in family medicine at the University of Kelaniya and Sri Jayawardhanapura, and now practices as a GP in Australia. Her academic and clinical interests include chronic disease management, women's health, and primary care leadership. At this session, Dr. De Silva will speak on obesity beyond lifestyle, and due to some technical problems, we are going to play a recorded version of this, but Dr. Aruni is online, and at the end of this recording, she will take questions from you. So can we have the recording now?
Very good morning, and thank you very much for the kind introduction. First and foremost, I would like to thank the college for giving me the opportunity to share my experience on management of obesity, and I also apologize to the audience for being unable to be physically present. And today, I would like to start my presentation by mentioning that I will be discussing about medication, and I have not received any sponsorship or any monetary benefits from any of the pharmaceutical companies. Right, so coming into the management of obesity, as you know, lifestyle management plays a major role, both exercise and diet. And also next comes the pharmacological management or the medication, and then you have the surgical options as well. But for today, what I'm going to focus mostly is on the medication or the pharmacological management of obesity. So how significant is the problem in Sri Lankan context? So if you go by the WHO Asian cutoff values in defining obesity, 25.2% of the Sri Lankans are overweight and 9.2% are obese. And if you go by the Caucasian cutoffs, the prevalence of overweight is 16.8% and obesity is 3.7%. So why do we need to focus more on managing obesity? So research has shown that weight loss, 5 to 15%, improves and or prevent progression of obesity-related comorbidities. And greater the weight loss, resulting in more substantial improvement in complications and quality of life. Okay, So, how do we approach managing obesity? Starting from the very basics, history, examination, and investigation. We do have to explore about the lifestyle, diet, exercise in detail, and also about smoking and alcohol. Mostly because smoking and alcohol are linked with other complications with obesity, and also these are to be considered when choosing the medication as well. So it is very important that we explore about smoking and alcohol and also address these issues if these are problems. Then determining the body mass index, examination and history exploring two possible secondary causes and also comorbidities such as diabetes, hypertension, ischemic heart disease, stroke, fatty liver, obstructive sleep apnea, osteoarthritis, disordered eating like bulimia nervosa, very important in exploring, and also mood. So it is very well recognized that obesity can be associated with poor self-image, which can lead to depression, anxiety, social phobias, and dysmorphophobia, etc. So evaluating the mental health is also an important aspect in comprehensive management of obesity. So what are the secondary causes for obesity? Acromegaly, ascites, Cushing's syndrome, hypothyroidism, iatrogenic Cushing's syndrome, insulinomas, genetic disorders like Kallman syndrome, idiopathic hypogonadotrophic hypogonadism, generalized lipodystrophy, polycystic ovarian syndrome, and most importantly, going through the list of medications that your patient is on is very important. The common medications like some of the medications used to manage diabetes promote obesity, and specifically medications like anticonvulsants and also antipsychotics. So mental health disorders per se is a risk factor for cardiovascular disease, and antipsychotic medication also increases the cardiovascular disease risk and also obesity. So exploring those and addressing these are very important in the management of obesity. So what are the things that we have to focus on the examination? Of course, measuring the weight, height, abdominal waist circumference, etc. is important. Measuring the blood pressure, screening for hypertension, and also looking for signs of insulin resistance like acanthosis nigricans, then features of PCOS like hirsutism, acne, and also looking for secondary causes like features of Cushing's syndrome like moon phases, buffalo humps, striae, etc. And also it is important to look for other complications related to obesity, especially obstructive sleep apnea, because this could enhance the other complications and lead to poor management of these complications such as diabetes and high blood pressure. So measuring the neck circumference, throat examination to see the malempathy score, macroglosia, micronathia, things like that. And also using tools like OSA 50 or Epworth's sleepiness score to objectively assess the severity of obstructive sleep apnea, and also detecting obstructive sleep apnea is important. Because all of these comorbidities has to be managed at the same time simultaneously with the management of obesity as well to improve the patient's health. So investigations, the very basics would be the sugars, the lipids, renal function, liver function, and also assessing the cardiovascular risk based on a tool which is relevant for the particular context. And of course, you can add a huge list here for tests that you could be utilized to explore for secondary causes of obesity, which I'm not going to focus in today's presentation. So as you all know, lifestyle modification is one of the key strategies in managing obesity, both diet and exercise. What we have to keep in mind, apart from weight reduction, both diet and exercise gives other health benefits. Healthy diet has shown to make you help live longer. It's good for your skin, teeth, eyes, muscle, prevention of osteoporosis, boosting up your immunity, and for healthy pregnancies and breastfeeding. It also reduces the risk of heart disease, diabetes, some cancers, and also it is good for your digestive system. It is known to prevent disorders like irritable bowel syndrome, diverticulosis, etc. And there are multiple types of diets which can be utilized to manage obesity, which I'm not going to focus on. But when you're choosing any of these diets, you have to consider how sustainable these changes are, how they are contributing or helping the management of the associated comorbidities, the safety of these diets in the long run, affordability, the nutritional value it offers, and whether these diets are addressing the food preferences and the cultural preferences as well, and how suitable are these diets for long-term adherence. Those are a few things that you have to think about when you're choosing a diet for your patient. Next, exercise, apart from reducing the body weight, it also has shown to increase the longevity, and also it reduces the cardiovascular risk independently of its weight reduction, and also improves the outcomes associated with chronic disease management such as diabetes, high blood pressure, respiratory diseases, etc. It reduces the risk of certain cancers, increases the bone health, prevents osteoporosis, improves muscle strength, and prevents falls as well. And above all, it provides benefits for your mental health as well. Exercise has shown to improve mood. It makes you feel more energetic, improves your self-confidence. It's a healthy way of distraction, getting distraction away from stress, away from other things like smoking, alcohol, etc. And exercise also helps to reduce anxiety and depression. Right, coming back to the main focus for today's presentations, the pharmacotherapy for obesity management. When is it indicated? If your BMI is more than 30 or if your BMI is more than 27 and is associated with complications related to obesity such as type 2 diabetes, dyslipidemia, hypertension, fatty liver disease, obstructive sleep apnea, and osteoarthritis. Okay, so now these are the main medications approved in Australia to be used in primary care to manage diabetes. So if you look at this table, you could see the topmost drugs. The best drug giving the highest weight reduction is tirzepatide, which is glucagon-like peptide and glycogen-like peptide 1 agonist, a dual agonist of these two, tirzepatide, which can contribute for a 15 to 20% weight reduction. Then we have semaglutide, once again a GLP-1 agonist, which can have a 10 to 15% weight reduction. So both of these medications are probably quite familiar because these medications are used to manage diabetes. Then we have phentermine, which is a norepinephrine agonist, and gamma aminobutyric acid agonist, which can contribute to 4 to 6% of weight reduction. Then we have topiramate, glutamate agonist, once again 4 to 6% weight reduction. Then we have naltrexone and buprenorphine, which are opioid receptor agonist and dopamine agonist and norepinephrine reuptake inhibitor as well, which contributes to a 4 to 5% weight reduction. Then the last one, orlistat, I'm sure all of you all are familiar with, which is a gastric and pancreatic lipase inhibitors. Basically, it reduces absorption of fat from your gut. So it has shown to have a 2.9 to 8.5% weight reduction. So now let's go through each one of these. Okay, this slide shows how GIP agonist and a glucagon-like peptide 1 receptor agonist helps weight reduction. On your left side in red color is the GLP-1 agonist. Mainly the example is the semaglutide, or the brand names comes as Ozempic or Wegovy. So it has an action on the central nervous system, increasing satiety, reduce food intake, increase nausea, and reduce body weight. At the pancreas level, it increases insulin, reduces glucagon, and in the stomach, it reduces gastric emptying, so you feel more full after a meal. And the systemic effects include reducing hyperglycemia. And it also has a function on the liver, increasing insulin sensitivity, reduce hepatic glucose production, and also reduce ectopic lipid accumulation. Then comes the gastric inhibitor peptide agonist, shown in green color. So on the central nervous system, it reduces food intake, reduce nausea, and reduce body weight. And also in the pancreas, increase insulin and glucagon. And also it has an effect on at the level of your adipose tissue. So your adipose tissue becomes more sensitive to insulin, increase lipid buffering capacity, increase blood flow, increase storage capacity, reduce pro-inflammatory immune cell infiltration, and also reduce hyperglycemia and also dietary triglyceride levels as well. So tirzepatide has a dual action. That means it has the actions from GLP-1 receptor agonist effect and also GIP agonist effect. So it's a combination. And tirzepatide was very recently approved, but it has a good safety profile with the current evidence. Of course, research is going on about these various actions at various levels and how beneficial it could be in conditions other than the management of obesity. Okay, so it has been found from research that the dual GLP-1 and GIP co-agonist tirzepatide has demonstrated superior efficacy in comparison to GLP-1 receptor agonist, that is like semaglutide, in reducing plasma glucose and also body weight. So semaglutide or tirzepatide have demonstrated benefit in heart failure with preserved ejection fraction, with fatty liver, in also osteoarthritis, obstructive sleep apnea, and secondary prevention of cardiovascular disease. So when these medications are used in the management of obesity, they give these additional benefits for the patient. Right. So semaglutide, which is a GLP-1 agonist, it's a subcutaneous injection given weekly. And the contraindications are personal or family history of medullary thyroid cancer and a personal history of multiple endocrine neoplasia 2 disease and pregnancy. And mind you, all the medications used in the management of weight are contraindicated in pregnancy. So what about the side effects? The main side effects are related to the gastrointestinal tract: nausea, diarrhea, abdominal pain, dyspepsia, abdominal distension, flatulence, and gastroesophageal reflux, and also pancreatitis. And it also have shown that there is a potential risk of having effects on retinopathy, but presence of diabetic retinopathy is not a contraindication for semaglutide. So it's a potential risk which needs more evidence for further confirmation of this suspicion. Right. So semaglutide, you do have to, given its like gastrointestinal side effects, it is recommended to start from a smaller dose and gradually titrate depending on the patient's side effects that the patient is experiencing. So it comes in pre-filled syringes, pre-filled pens. So basically, when it comes to semaglutide, it comes in two major brands, the Ozempic and the Wegovy. In Australia, Wegovy is the one recommended or approved for the weight management, and Ozempic is recommended for mainly diabetes management. And so this picture shows how the Wegovy dose is titrated. So you start with 0.25. So then you have 4 doses for the first 4 weeks, and then you go for another 4 weeks of the higher dose. Gradually, every 4 weeks, you can gradually go up until the maximum dose of 2.4, or reaching the maximum dose tolerated by the individual patient. And there is no dose adjustment requirements based on the liver and kidney functions. Right, this is what I just mentioned. So we have two main brands, Ozempic and Wegovy, and the dosing schedules are slightly different for these, even for weight management. But both of them can be used in patients with diabetes and also without diabetes. Right, so tirzepatide, it is once again a weekly subcutaneous injection. The contraindications and the side effects are mostly the same. Contraindications include personal or family history of medullary thyroid cancer and multiple endocrine neoplasia type 2 and pregnancy. Side effects mainly gastrointestinal and also pancreatitis. So when you are counseling the patient, it is very important to discussing these side effects and also excluding the contraindications. Telling them that mainly the gastrointestinal side effects are shorter. Most of the patients overcome with time, but if these effects are persistent, then the patient might have to go down on the dose or go for a different option. So it's also important to tell the patients the possibility of pancreatitis and the concerns that if they are experiencing severe abdominal pain, so that they can discuss with their doctor that they are on these medications to make things easy in the diagnosis. And tirzepatide, like semaglutide, do not need any dose adjustments based on the level of renal and liver functions. So tirzepatide can be started from 2.5 milligram per week. So like for semaglutide, it's a weekly subcutaneous injection. So you can go up on the dose every 4 weeks to a maximum of 15 milligram per week. Okay, this graph shows from a research comparing semaglutide to tirzepatide. So you can see in achieving weight reduction of all these 3 categories, 5%, 10%, and 15%, you can see that tirzepatide is superior to semaglutide. And this graph shows that longer you use these medications, both the semaglutide and tirzepatide, it is associated with a greater reduction in the body weight. And you can see that people who do not have diabetes have a greater reduction in the weight as well. I don't know what's the reason is. Right. All this time I was discussing the content from an article published in the HHEP, which I have shared previously. But this bit of information is from the website of Tersepatide, the brand Mounjaro. They have mentioned to discuss this issue with the patients about the possible risk of medullary thyroid cancer, and also to make them aware of the possible presenting symptoms like a neck lump, changing in voice, dysphagia, etc. But even this the manufacturers do not recommend things like routine calcitonin checking or a regular ultrasound to detect this rare complication. Right, liraglutide is once again a GLP-1 receptor agonist, also used to manage diabetes, but it's a once daily subcutaneous injection, making it a little bit unpopular, but it's cheaper than the other two medications. So tirzepatide is more expensive than semaglutide. So you can go with a starting dose of 0.6 weekly and go up to 3.0 milligrams weekly. Then comes the medication phentermine. The brand name in Australia, the common one is Duramine. So it's an appetite suppressant. It's oral medications once daily. You can start with 15 milligrams and gradually titrate as required up to 30 milligrams. So it has symptomatic side effects, which limits its tolerability. So the contraindications are cardiovascular disease, cerebrovascular disease, uncontrolled hypertension, pulmonary arterial hypertension, extensive valvular heart disease, heart murmurs, arrhythmias, atherosclerosis, hyperthyroidism, glaucoma, and psychiatric illnesses, and patients being on MAO inhibitors, SSRIs, pregnancy, breastfeeding, and also alcohol, drug and alcohol dependence. So once again, this emphasizes when you're evaluating the patient, the importance of exploring these areas, the patient's cardiovascular risk, the mental health, and their drug and alcohol behaviors are important. And for this medication, monitoring is recommended, especially heart rate. It can increase the heart rate and blood pressure, and also assessing the mood as well, at least every 3 months. The common side effects include dry mouth, constipation, insomnia, closed-angle glaucoma, agitation, depression, and suicidal ideation. So if you are starting this medication on patients, you have to make sure that they have literally very low risk of going into depression, and periodically assessing their mental health is very important. Next medication is topiramate. So this is a common medication used for prophylaxis for migraine and also in the management of seizures. It's an off-label pharmacotherapy for managing obesity, and you can start with a dose of 12.5 once daily and go up to 50 milligrams twice daily. The common side effects include glaucoma, confusion, memory loss, renal stones, nausea, vomiting, and once again pancreatitis. Contraindications include glaucoma, renal stones, and pregnancy. Right, so the next medication, naltrexone, and it's a combined medication, naltrexone plus bupropion, which is known as Contrave. And naltrexone is an opioid agonist used to treat alcohol use disorders and also opioid dependence. Naltrexone blocks the effect of opioids and prevent opioid intoxication and psychological dependence on opioid use. And also it can cause withdrawal syndrome in patients who are already on opioids. So a medication history is important. Opioids could be either abused medication or it could be a prescribed medication for chronic pain, cancer pain, etc. Buprenorphine is a synthetic opioid developed in the late 1960s, and it is used in the treatment of pain and once again in opioid use disorders. So, what are the common side effects? Nausea, constipation, headache, vomiting, dizziness, increasing the risk of seizures, risk of opioid overdose, depression, suicidal ideation, hepatic toxicity, and angle-closure glaucoma. The contraindications are uncontrolled hypertension, seizure disorders, opioid use disorders, anorexia, bulimia nervosa, abrupt discontinuation of alcohol, patients on benzodiazepines, barbiturates, or anti-epileptic drugs, and also on patients on MAO inhibitors, monoamine oxidase inhibitors for the past 14 days, and also pregnancy. So because of the complexity and there's multiple contraindications, multiple side effects, it's not quite a popular medication, especially I hardly have any experience in prescribing this medication because of the complexities and the side effects, etc. So if you are prescribing this medication, do not crush or chew the tablets. You have to start one in the morning and then you can increase the dose. Dose adjustments are required for patients with renal and hepatic impairment. Concomitant use of liver enzyme inhibitors should be avoided. If this is not possible, the maximum dose should be reduced twice daily. So I am not sure whether this medication is available in Sri Lanka, but I am just including this in my presentation for the sake of completeness, and because most of you all will be planning to come to Australia for your post-MD training. So for the sake of completeness, I have included this medication as well. So next comes Orlistat. I'm sure majority of you all are quite familiar with this medication. It has been there in the market for a long time for the management of obesity, and it is a inhibitor of gastric and pancreatic lipase, and the mode of action is inhibiting or reducing the absorption of lipids from your gut. So all the side effects are associated with its action. So steatorrhea, flatulence, abdominal discomfort, and also fat-soluble vitamin deficiencies. It's contraindicated in malabsorption and pregnancy. Its effect is mostly seen in people who are prone to have a more fat-rich meal. The dosage, it's an oral tablet, 120 milligrams 3 times a day with your meals. The other medications which are beneficial in reducing weight but yet not recommended solely for the management of obesity are dulaglutide. Then you have the sodium glucose cotransport 2 inhibitors like empagliflozin and dapagliflozin, and also metformin. All these 3 medications are beneficial in patients with diabetes and obesity, and it helps to reduce the weight in these patients. But in the absence of diabetes, these are not recommended to be used for weight management. So how do you choose the treatment for your patients? For patients with diabetes, cardiovascular risk, knee osteoarthritis, obstructive sleep apnea, fatty liver, the GLPA1 receptor agonist and the dual GLPA1 and GIP agonist are recommended as first line, but these are quite expensive in the Sri Lankan context. So the other factors that you have to consider are the affordability and the presence of contraindications. Okay, the follow-up is very much important. At the initial phase, it's important that you follow up monthly looking at the side effects and the compliance for the medication. Once the patient is stable and quite comfortable with the medication, you can do 3 monthly reviews. So if the patient is not able to achieve a 5% weight reduction over 12 weeks on the maximum recommended dose for that particular medication, then you should consider discontinuation and changing for a different option. If the patient's BMI is more than 40, it's ideal to seek specialist advice in the management. So surgery is the next step in the management of obesity. It's indicated for patients with a BMI of more than 40 or for patients with a BMI of more than 35 with other comorbidities. So just sharing one of my patients' static weight reduction journey. So this patient was a 44-year-old male. So you can see the patient was started on Wegovy with a dose of 0.25 milligrams, which went for 4 weeks, then 5 milligrams for 8 weeks, and 1 milligram for 4 weeks. So over the 16 weeks, he was able to come down from 144 to 133, which is an 8% weight reduction, even without being on the maximum dose of Wegovy. And thank you very much for your kind attention. And if you do have any questions, I'm happy to respond. Thank you very much.
Have you got any questions? We can give one question.
Hello.
Hello.
Arune.
Hello.
It's me, Lalanta. Yeah.
Yes.
So now what is your experience of using topiramate for the weight reduction?
Actually speaking, topiramate is like quite freely available, but I'm in here, of course, it's like semaglutide and tirzepatide. None of the patients opt for anything else. So because they know the efficacy and because they come to us with the word of mouth from other patients who have success stories. So basically my experience is mainly with semaglutide and tirzepatide. And the people who can't afford, of course, the option is like Orlistat. But the next popular one, I would say it's phentermine. So tirzepatide and Contrave hardly used, given the side effects and lots of constricting contraindications and stuff like that to go through. Yeah.
Yeah, the second one is the use of metformin. Is it weight neutral or, it can cause some weight reduction? So what's the use of that,
Anyway, metformin is not recommended solely for weight management.
Yep.
Of course, like if it for the management of diabetes for certain patients, you might expect a weight loss, but it's weight neutral and yeah.
Okay, thank you.
Yeah, thank you for the questions.
Is there any other questions? One question, or can I just ask one?
Aruni,
Yes, sir.
here Malkanti.
Yeah.
I would like to know your experiencing regarding the effects of the semaglutide which you are using, and I heard that there is a trend for like the patients are coming like addicted. So can you let me know the positive effects?
Yeah, addiction per se, I don't think it's a medication of addiction, but I mean, it's highly effective. Semaglutide is slightly cheaper than the tirzepatide, which is more effective than semaglutide. So patients know, because you can see like for most of the patients, coming down in 10 kg is a dream of their lifetime. So if you can achieve that within 3-4 months, that's amazing for them. So they definitely come for the GP, specifically this medication, but unfortunately still in Australia it's not provided under the cover of the government cost. So it's an out of pocket which comes to around 3 to 400 Aussie dollars for the patient, but still they come for it. And it's quite safe. Apart from the gastrointestinal side effects, if the patient is suffering from that, we can always step down from the higher dose to a lower dose. Then they can remain on that. And even the studies like the research done, they have continued the medication for 12 months or so from the published research. So it's quite safe. And the only reported severe side effect is pancreatitis, which is also rare. So I haven't come across any of my patients presenting with pancreatitis. Most common are GI side effects, and which is very well managed by gradual titration of the dose and also stepping down if the patient cannot tolerate.
Thank you, Aruni. Thank you, Aruni.
Yeah, you're welcome.
Just the final question, Aruni.
Yes,
This
sir.
is about lifestyle. We always recommend lifestyle modification as a first choice. But 2025, just June this year, BMJ published a review that although we have recommended lifestyle modification, on the long run, it does not help at all. So I have been doing this for a long time before I recommend lifestyle and at least give them Orlistat so that they can at least within the first 3 months see their weight is getting down. What is your view? Because we have been putting a lot of weight that does not in the long run sustain this. What is your experience, Aruni?
Yes, sir. It's very true. So most of the patients, anyway, based on the guideline, they still recommend lifestyle modification as the first step. So most of the patients who come to us, they have already tried all means of lifestyle modification, and they want some sort of an additional help to come down on weight. So that's very important. And the sole reason I just wanted to highlight in my presentation about lifestyle and diet, as I have presented in my presentation, is the additional benefits. So therefore, even though you do not come down on your weight with lifestyle modification, still it's recommended because you have other additional benefits, especially when it comes to exercise and stuff, with the mental health benefits, which is joined with that as well. Therefore, as primary care doctors, yes, don't hesitate to go for pharmacotherapy for weight management, but you do have to continue preaching them about the lifestyle because it has other benefits. And solely being on lifestyle to manage weight is a thing of a past, I should say.
Thank you.
Yeah, one last question. Excuse me, Dr. Arune, can I know that how long one has to use this GLP-1 stimulators? How long? We know that all the drugs and the mechanisms, once they stop, weight regains. What about this?
That's the other problem. So that is why you have to combine with the lifestyle modification. So once you come off, you can at least maintain the weight reduction to a certain extent. So very recently we had a discussion with one of the pharmaceutical companies and expertise on these medications. What they said is there will be, once you come off completely of this medication, there will be a rebound, a weight gain, but most people are able to, avoid going back to the previous weight. So they will remain somewhere in between the starting weight and the weight that they have achieved through the medication. So once you have achieved the weight, from there onwards, you have to consistently talk to them about maintaining a healthy lifestyle so that they don't bounce back to their previous weight. So that remains a challenge still. Yeah, but as the evidence is good, I mean, people don't go back rapidly to the previous weight. So that's the good news for the time being.
Thank you, Aruni. I think you have spent a long time on the medications, which is a very appropriate thing than lifestyle only. Thank you very much for it. The audience has a huge, I think, 5 or 6 medications that they can now use for the patient with the most appropriate drug. Thank you very much for updating us on the current management.
Okay, so you're very welcome.
Right. That concludes our symposium number 2, and I would like to thank our speaker, Dr. Arni Veerakon, as well as the chairpersons, Professor Kumara Mendis and Professor K. Arulanandam. Thank you very much, sir. And we are moving on to symposium number 3. That is on primary care perspective on aging with dignity. And to conduct the symposium, I have great pleasure in inviting the chairpersons, Dr. Clement Pereira, specialist in family medicine, works at Base Hospital, Minuangada, and also Dr. Hiranthi Nidi Silva, who is a specialist family physician in Sri Lanka and as a specialist GP in Australia as well. So I have great pleasure in inviting Dr. Hiranthi Nidi Silva as well as Dr. Clement Pereira on stage to conduct symposium number 3, primary care perspective on aging with dignity.
Good morning. So we have now come to the symposium 3 on primary care perspective on aging with dignity. And I would like to invite our speaker, Professor Kandasamy Arulanandam, and his topic for today is approaches to managing multimorbidity in the elderly. Professor Arulanandam is a professor in family medicine in the Department of Primary Health Care, Faculty of Healthcare Sciences, Eastern University, Sri Lanka. He is a distinguished professor in family medicine and a board-certified consultant family physician with decades of clinical, academic, and administrative experience. He was board-certified as a consultant after completing both local and overseas training, including a fellowship in the UK. Currently, serving as head of the Department of Primary Healthcare at the Faculty of Healthcare Sciences, Eastern University. He is also a postgraduate trainer under the Postgraduate Institute of Medicine. Professor Arulanandam has contributed extensively to research in elderly care, diabetes, hypertension, and health systems. He has more than a dozen publications in peer-reviewed journals and authored several books in both English and Tamil. He has made numerous research presentations at national and international conferences. In this keynote, he will speak on approach to managing multimorbidity in the elderly. Over to you, Professor Arulanandam.
Good afternoon to all. First of all, I take the opportunity to thank the college to have this session. Today's topic is to discuss on approach to managing multimorbidity in the elderly. During this short time, we will discuss about a case of Valen, an elderly person. But this multimorbidity has multiple long-term condition latest definition. Understanding the etiological factors and major challenges in clinical management in among elderly. What are the practical patient-centered plan of care? Now we think about a case where Valen, 82-year-old gentleman, meets a doctor and says, "Hi doctor, I feel tired all the times. I can't enjoy anything which I used to do. What is his problem?" Now he's old, 82. He has a vast history of hypertension, type 2 diabetes, COPD, osteoarthritis, CKD stage 3, dementia as well. He is on a lot of drugs now. Losartan, amlodipine, HET, atorvastatin, aspirin, gliclazide, insulin, calcium carbonate, alpand, and these inhalers. Now he has a social history as well. He lost his wife and is living with the only son's family. Then when we discuss our term, multi-morbidity or multiple long-term condition, it is the coexistence of two or more chronic medical conditions in one individual. It was clearly stated by this authors in 2023. Now we can see what is the multi-long-term conditions. It is the norm rather than exception. A large proportion of the global population, especially those 65 plus, are affected by multiple long-term conditions. It affects 1 in 10 of urban South Asian. When we see our country, our Sri Lankan, 64 has more than 2 NCDs by the time they reach 50. And 77% above 65 has 4 or more diseases. Then we should know about the etiological factors. Physiological aging. When you think about aging, it is inevitable, progressive in nature. It can be visible, invisible. Therefore, it is a nature we are going to growing. Then elderly or even anyone can grow with aging. That cannot be prevented. And at the time, you keep on accumulating risk factors, as we mentioned, all the risk factors, but we see in the environment or social, wherever, that is also adding up. Then we are trying to improve our health. Survival expectancy is also going up. To live longer, are we living happier or healthier? Then with that, the diseases are coming one by one. At the age of 40, start with NCDs. At again 60 onwards, develop something and end up with mental disorder. Therefore, these are the main etiological factors for an elderly with multimorbidity. Actually, what are the challenges we are going to face? Number one is a polypharmacy. Multiple medication by multiple professionals for one problem or more than that. The treatment burden and the patient capacity. When you go aging, there's a decline of all the organs. Renal, cardiac reserve, lungs, everywhere. Therefore, there's a treatment burden and the patient capacity. And competing outcomes and we have prioritization. There's a cost and income and natural decline. So when you see this polypharmacy, hypertension, diabetes, CKDs, COPD, all will come into one. Then patient will have more than 10 or 12 or even 15 medication. It becomes a challenge. Then we should know actually what are the real problems in the body as well as by the drug. When we talk about the pharmacodynamics and pharmacokinetics of a medication, you know what is pharmacokinetics? There is a gradual decline of clinical significance and there is a renal clearance, drugs undergoing metabolism and reduced elimination of renal part. Then when there is a high individual variability in organ or system functions and their homeostasis status. In the pharmacodynamics, there are increased and reduced sensitivity to drugs. With that, there are other influences, pharmacokinetics, comorbidities, including drug disease interactions, co-medications, and drug interactions and fragility. And also, in all, it will be a multiple cause for these medications. Then you think age itself is increasing a risk factor. There's no doubt it's a risk factor. Multiple providers are coming to treat elderly. They have already introduced new medications. And there is a number of medications moving from prescription to over-counter. They take their own medication, skill-seeking behavior, doctor shopping. Then recent and multiple hospitals, when they get some problem, they got admitted, they are introduced new drugs, then adding to the list. Then along with that, we are also happy to use that herbals and the pharmaceutical industries and to try and see that whether we can improve quality of life. Therefore, these all will increase the burden for the human. Then we have to think whether the treatment burden is going to be and the patient capacity, whether he can cope up or whether he's going to go further down. The treatment burden, you know the workload of being a patient, he becomes patient and he is more becoming declining. and he has more and more appointments. He had to undergo tests and introduce medicines, and she also has to take self-care as self-monitoring part. Then ultimately, that quality of life is almost in a different field. Then patient capacity, as I mentioned, age itself is one of the important natural factor. And fragility, unavoidable, we can mention osteoporotic muscle changes, all can lead to fragility, and naturally cognitive impairment is possible. Therefore, what can we do? We have to make a good decision. Are we going to do what are we going to do? We should have some goal to manage this multimorbidity or multiple long-term conditions. Think, are we going to keep on giving medications? Or are we going to tight control of blood pressure or even diabetes? Are we going to be disease management or patient management? As we are patient-centered or goal-focused. Then think about the economy. How much we are spending for medication. For one disease, medication 3. Then you keep on adding to the drug, then it is also increasing the cost. Then who is going to feed them? They are almost on the job, they are being independent on other people or on pension. Therefore, there is another economical burden onto the patient. These are also coming as burden. When you see the WHO, it has clearly stated, people 60 years and age older, 600 million now. They are forecasting to reach 2 billion in year of 2050. Then it was a big challenge. Person aged 65 and older constitute 13% of the population and purchase 33% of all prescription medication. They are the most common consumers. By 2040, 25% of the population will purchase 50% of all prescription drugs. Then this is a big challenge on social, economical, and medical side. Then naturally, there's a progressive decline organostenosis. All the organs are coming smaller. Whatever the doctor's actions we take, the health will decline. We can only slow the progress of the nature. One point of time, patient with multi-tone condition would not be able to come to us because they are almost bedridden or in a different position. Therefore, we have to need to accept the reality of aging and think about the multimorbidity. Then how can we overcome this? To overcome this, we would have a 5-step approach with principles based on our family medicine. Comprehensive geriatric assessment, elicit patient priorities and goals, reconcile guidelines with patient-centered or patient context and priorities, embrace team-based care, schedule proactive, plan, follow-up. Then cut and do on comprehensive geriatric assessment is a must. Understanding the whole person as a holistic approach, we should know from how this patient is having that. We are assessing the functionality. We are not worried about his, we are assessing the functionality, whether he can cope up with these social settings. Think about the factors involved in social network, whether he can be functional, whether he can be environmentally friendly, whether he can adapt to the medication, and whether he can have a psychosocial support. These should be assessed on terms of functionality. Then we should think about the patient priorities and goals. Asking the questions, right questions, then only right answer will come. What matters to him and to what matters to you? Because he might be worried about medicine, not the medicine, the household environment. What does a good day for him? What are you can do and do not want to achieve this not. Aligned with the care plan, with the patient's goal. That is our aim. Then can we just say no? We have to go with the guidelines and see, we have to make it unified, personalized care plan. You can't, it's an individualized care plan. Review the medications, that's lacking part in our country. Almost all the clinics, we fail. We do not review the drugs. In developed countries, they have a clinic on drug review clinics. Unfortunately, we don't adapt. We keep on patient RPT, repeat for months and months. There's no review. Yeah, review medication is a must. initiate deep prescribing. We should not give all the drugs. We can reduce. Then we bring these simplified regimes, either 1 or 2 drugs. We can make it clear, and the dosage and the route. Think to goal to create a single coherent and feasible plan that balances the evidence with patients' individual capacity, goals, and prognosis. Then how can we work? Can we work alone? No, we have to be the team. Team can be with many people, but our goal should be very clear. How can we work? We should work as a team, and our task should be met, and best person reducing the burden on the patient, and we should improve the health care of the patient. Then what can we do? It's a proactive plan follow-up. Difficult to manage multiple conditions within 15 minutes of a consultation time. They are feeble, poor in communication, poor in coordination. Somebody had to bring them. It takes more time. They will spend more time. Need dedicated longer than usual appointments. It's a challenge. And time limited on therapeutic trials. And we had to think about monitor what matters. Are we going to improve the life expectancy, or are we going to improve the quality of life? Then what can be done for a case of valent? This is a message we should talk. Do not be afraid to deep prescribe, and do not be we have to therapeutic trial. We should follow the 5 steps approach: comprehensive assessment, guidelines, follow-up. And we have to deep prescribe something which is not relevant at the point, and we can review the drug in 1 month's time and check the blood pressure, and we can control the lipid levels. And we have to observe importantly whether his energy levels are improving. And for demented patient, we should think about the support care system. Therefore, we should arrange a standardized or standard home visits to the patient. Therefore, this is the problem in multimorbidity. Most of the patients are suffering because they are not supported well. We don't have a national policy just to look after elders. We are seeing as equal patients, but we should think about the dignified care. Are we going to provide dignified care to the elderly population in the future? This is the biggest challenge. Thank you.
Thank you for that informative lecture. The forum is open for questions.
In the absence of questions, shall we please wait for the appreciation of token.
Well, ladies and gentlemen, that was Professor K. Arulanandam, and to give away the token of appreciation, I invite the chairpersons to come forth and give away the token of appreciation. So the first speech was Approaches to Managing Multi-Morbidity in the Elderly by Professor Kandasamy Arulanandam and Dr. Clement Pereira and Dr. Hirantini Silva. The chairpersons are giving away the token of appreciation. And I believe we'll be commencing the paper presentation, so we'll have to excuse Professor Arulanandam for that. So handing over the proceedings once again back to the chairpersons.
It is my privilege to introduce our next speaker, Dr. Lalantha Senaratne, consultant family physician at Base Hospital, Homagama, an outstanding clinician, teacher, researcher, and leader in family medicine. Dr. Senaratne graduated with her MBBS from University of Ruhuna. She specialized in family medicine, obtained her diploma in family medicine and her MD, with include overseas training at Monash University, Australia. She was board certified as a consultant in family medicine in 2013. She has served as a lecturer, trainer, supervisor, and examiner, guiding numerous postgraduate trainees and research projects with special interest in rheumatology, diabetes, and women's health. Founding president of the Sri Lanka Association of Specialist Family Physicians, she has also contributed to national guidelines, curriculum development, and palliative care initiatives. Her lifelong dedication to clinical service, teaching, and leadership and has made her to true pioneer and role model in family medicine in Sri Lanka. Today, she will deliver her lecture titled Shaking Hands in the silver years. I am warmly welcome you, Dr. Lalanta, and over to you.
Thank you very much, Chairpersons, for your kind words. So the topic, shaking hands in silver years. Yes, that's a presentation of patients for us. So in the medical perspective, what's it? Shaking hands would be abnormal movements, silver years, elderly. So we are dealing with a patient, the elderly person with some movement disorder. So that's the topic. I would like to touch all these aspects within this 30 minutes. I don't know, the time is there. Yes, I'll try my best to finish it off, but it says 25, but maybe I take 30 minutes. So I would like to introduce is like this. Yes, the hand tremor is a very common sign of old age. We don't take it serious, but it's not a dangerous factor for the health of elderly, but it's always a challenge for us because the shaking hands or abnormal movements of hands in old age may arise from wide spectrum etiologies. As like physicians, we should know why the person has come with this movement disorder. So it's our duty to do the proper assessment of this her or his problem. So I describe like this, the body movements depend on complex integration between the central nervous system, motor pathways, and skeletal muscles. Disruption at any point in this network can result in abnormal movements in the body, collectively described as movement disorders. Yes, what are those? So these are the neurological syndromes, that is collection of symptoms and signs that involve impaired performance of voluntary movements, dysfunction of either posture or presence of abnormal voluntary movements. So the movement disorders are divided mainly into two categories: hyperkinetic movement disorder, sometimes referred as dyskinesias, or hypokinetic movements, or as we can as akinetic or rigid disorders. So symptoms of movement disorders mainly vary depending on the type of these disorders. So there are different, because I would like to, because we do not know what it is, the person comes with just a kind of a movement, like maybe they come shaky hands, we don't know what are those. So these are the several types of movement disorders we'd like to talk about. Akathisia, just think what are those, and this intense sensation, the patient feels intense sensation of unease or inner restlessness. This results in a compulsion to move and can cause extreme distress. The other thing is ataxia, you know that, loss of muscle control that leads to lack of balance and coordination. It's a clinical finding, but it's not a disease, which mainly presents abnormalities in gait, changes in speech, and abnormal eye movements. Chorea, a state of excessive spontaneous movements that are irregularly timed, non-repetitive, randomly distributed, and abrupt in character. Athetosis is a slower form of chorea. So now what's chorea? You know the choreography. It's like dancing. You know that's how to differentiate. Chorea is like dancing. Right. The dystonia, I'll talk to that later also. I'm just telling what it is. An involuntary maintained contraction of agonist and antagonist muscles, yielding abnormal posturing again, twisting and repetitive movements. And the other one is myoclonus. We have to differentiate one from the other. You better sit and read again. As an involuntary and uncontrollable muscle contraction disorder consisting of sudden, brief, and lightning-like movements of specific muscle, group of muscles, or even in the entire body. Most muscle contraction results positive myoclonus or sudden muscle relaxation, that is result negative myoclonus. Tics. We all know that are tics. Tics are brief, sudden, repetitive movements and or sounds. They are divided into motor tics, that means the blinking, shrugging of shoulders, grimacing or jerking, or vocal tics, that means throat clearing, sniffing, grunting, or more complex utterance. But it's all are tics. The tremors, which are the most common movement disorder, which I'm going to discuss with you all. So what are tremors, right? The hand tremor is defined as a rhythmic oscillating movement with a certain amplitude and beyond the body's control. The level of tremor can vary from mild to severe, and any form of severe hand tremor can have a negative impact on activities of daily living as well as quality of life in elderly. That is the point the people come to you. If hand tremor occurs acutely, it's a manifestation of a newly developed physical pathology such as cerebral stroke. Therefore, in the elderly, it is necessary to approach hand tremor from many different aspects, systematically evaluate for accurate diagnosis and appropriate treatment. So they were classified into two major, the normal or pathological. Normal means the physiological one. The physiological tremor usually barely perceptible, you don't feel it, but becomes noticeable in many people during physical or mental stressors. When visible, this tremor is referred to as enhanced physiological tremor. So tremors vary in pattern of occurrence, that means intermittent or constant, and the severity, onset, that means gradual or abrupt. I just talk about, because we have to talk about these slides more otherwise we cannot move on. What are those? We have to understand those tremors very clear. We must have the very clear idea. What are those main types? Rest tremors or action tremors. There are a few action tremors which I am going to discuss later. The action tremors are postural tremors, simple kinetic tremor, intention tremor, orthostatic. There are a lot of kind of tremors which I will be dealing with later. Yes, this is how you differentiate. Rest tremor is a tremor present in the body part that is not voluntarily activated and is supported against gravity. The first slide you can see is that it's it's kind of is against gravity. The second part is the action tremor, is any tremor that produced by voluntary contraction of a muscle, such as writing, drinking. Just take that as an example, but I would like to nicely describe what are those. Postural tremor. Postural tremor is present whilst voluntarily maintaining a position against gravity. If you want to keep our hand like this, it's how we maintain. In that position, if we have this tremor, we call it as postural tremor. Kinetic tremor, there are three types of kinetic tremor. That means you try to move, some kind of a voluntary movement. So there are three kinds of voluntary, like the kinetic tremors: simple kinetic, intention tremors, and the task-specific tremors. Simple kinetic are tremor occurring during voluntary movement that are not target-directed. We just raise our hands, we just do something, it's not target-directed. But intention tremor are tremor during target-directed movements. So then we want to touch something that is target-directed. When we reach, the amplitude increases, and we can visually guided movements. If you want to go for a target, some point of a target, the tremor, the amplitude is more. And the task-specific movement, kinetic tremors, may appear or become exacerbated during specific activities. That means only for specific activities. For instance, if you write, then during writing you get these tremors. When you do something, maybe musicians, they get those tremors. So those are task-specific tremors. The other one is isometric tremors. These occurs because of muscle contraction against a rigid stationary object. When they lifting heavy weights or something, when they move with a heavy object, then they get tremors. Those are called isometric tremors. Orthostatic tremors are very high frequency, in the frequency between 13 to 18, and it is in the legs or trunks that occurs when standing but disappears upon walking, sitting, or lying down. So these, of course, I would like to talk about the frequency and amplitude. You know what's the frequency? More cycles, and the amplitude is, it's going up and down like this. Of course, you know what is amplitude and what is frequency. So we can nicely differentiate those tremors by looking at the patient. Because I just want to rush, there are a few things, slides I would talk. So this is a very, very important slide I would like to share with you all. So this, go through those things. The first thing is, the first part is the type of tremor. The second is the frequency, amplitude, occurrence, and associations. This is very important. What is a rest tremor? The frequency is low or medium. Low frequency one, but when it goes to talking about amplitude, high amplitude. And what are the occurrences? The limb supported against gravity. Those are rest tremors. I described the associations are Parkinson's disease, drug-induced, vascular midbrain lesions, less commonly atypical Parkinsonism. And then we talk about action tremors. The postural tremors, the frequency is a little bit high, medium to high, and the amplitude is low. Very fine ones, increases with voluntary movements. And its occurrences are the limb maintains position against gravity, as I told you. And the associations are physiological, essential tremors, thyrotoxicosis, hypoglycemia, Cushing's, and etc. Those you can see all these things. And simple kinetic, that means that does not change with target-directed movements. They are not like, it's not target-directed. This frequency is variable, and the occurrence, very simple movements of the limbs, right? Again, it could be essential tremors, dystonic tremor, I would like to talk about later, and enhanced physiological tremors. Intention tremors, the frequency is very low, and the amplitude is increased with the target-directed movements. I told earlier also. And these are, of course, the associations of cerebellar lesions. For instance, it could be multiple sclerosis, stroke, mass lesion, drugs, chronic alcoholism. Task-specific, again, the frequency is variable and amplitude is also variable. Occurrence is task-specific task only. What we are told is like maybe tremors they have while writing, or what you call as musician's tremor. And isometric, as I told earlier, is a medium frequency, variable amplitude, and muscle contraction against stationary object. And the essential tremors, enhanced physiological tremor, and the dystonic tremor. In this chart, we can see the table. The physiological tremors could be the postural, or it could be task-specific, or the isometric. So the presentations will be different. So if we talk about the etiology of the tremor, the physiological tremor, of course, we all know. So it occurs in otherwise healthy people, and it is actually an action or postural tremor that tends to affect both hands about like equally. Amplitude is usually fine. So I don't want to talk about these are the instances you get the physiological tremors. I would like to go to the other slide. Causes of pathological tremors. For action, including postural tremors, mainly the essential tremors. For resting tremors, we talk about Parkinson's disease. For intention tremors, we talk about cerebellar dysfunction. So sometimes it is strokes, trauma, multiple sclerosis. Even the endocrinologic or metabolic causes can cause some tremors. That means anoxic encephalopathy, heavy metal poisoning, hypoglycemia, hyperthyroidism, and hyper or hypoparathyroidism, hepatic uremic encephalopathy. All these causes tremors. And it's again another interesting thing, drug-induced tremors. Like, you better look at the medication on the left and the postural, resting, and intention tremors. majority of the medication can cause postural tremors. And there are some medications can cause resting tremors and some causes intention tremors. Though we say intention tremors are most of our pathologic, but still the drugs can cause these intention tremors. Like look at it, the ethanol, it can cause postural resting as well as intention tremors. The same as the lithium can cause postural, all three types of tremors. That's of course you have to understand the two, like postural and resting tremors can cause SSRI and valproate. There are some, you better go through this chart, it's very sort of interesting to know what are the drugs can cause different kind of tremors. And these are kind of complex tremors, like the Holmes tremor, what you call as midbrain or red nucleus rubral or thalamic tremors, is a combination of rest, postural and intention tremors caused by midbrain lesion. So sometimes there are those patients having ataxia or weakness, right? And even chronic relapsing polyneuropathy, it's again variable tremor type and frequency, usually postural and intention tremor in the affected extremities. Again, another entity is IgM neuropathy, is a abrupt onset and it's spontaneous remission of complex mixed type tremor with changing current. Why I want to tell you all these things, if you come across a patient with this kind of presentation, non-specific variable presentation, think of these very rare ones. And the Wilson disease, what I put it in red, it's not in elderly or in silver years, it's more common in very young adults or the children, right? So this is the most important for you all. And it's evaluation of patients with tremors. So nothing can substitute a good history and good clinical observation in evaluating a patient with tremor, right? For history, you should include the following: the age of that tremor onset, that's what I said, different tremors, the onset is different, and age at stepwise deterioration, mode of action, sudden or gradual, anatomical site, sequence of spread, familial spread. Those are the things you should go through all these things. And the second thing is physical examination. The purpose of this examination is very important. For why we have I'm always telling my trainees why you do examination. It's for you gather information in the data gathering part, why you proceed to the physical examination to find out the proofs, right? To give some evidence. The purpose of this examination, you must have some objectives before you examine the patient. The purpose of this examination is to confirm anatomical location of the tremor, identify tremor components at those sites, that means rest tremor, postural, intention tremors, etc. Document tremor severity. There are two ways I will be leading with that: spiral drawing or handwriting. Identify other neurological and general medical signs. Consider patient's psychological and psychiatric state. Differentiate tremor from clonus and rhythmic or levodopa-induced dyskinesia, epilepsy, rhythmic myoclonus, etc., right? And these are the essential maneuvers you should do for patients. Arms resting on lap, yes, to understand whether it's a resting tremor or not. So don't look at the patient as straight, just give the attention to something else and look at the patient's arms, whether it's a resting tremor or not. And extending arms in front of the body and finger nose test. It is first is for to just check with the action tremor or not, or the postural tremor, or holding a cup and drawing a spiral, determining functional limitations. So I would like to give the diagram. Could you please look at the first one? Number one is a straight line. It's sort of it's a very smooth. The patient without any pathological tremor. It's very straight line. Second one, the straight line again, it's sort of like there's a turbulence, right? So that means it's a cerebellar tremor. The amplitude increases as the finger nears the target, right? And the third one, in patients with Parkinson's disease, tremor may be present at the beginning of the movement and smooths out near the nose, right? And the other one, the fourth one is, the essential tremors manifested throughout the chest, possibly worsening as the finger approaches the nose, right? Like, remember all these things, and it nicely indicates the spiral drawing. The normal, you can nicely do it. The Parkinson's, I will go to the back. Parkinson's at the end, like it's nicely, it's smooth. So because of that, though it's small, it's nice, it's smooth. There's no tremor. The essential tremor, we can compare the fourth one. Whole thing is like, there's a turbulence. Because of that, the essential tremor, the whole thing is like, this way. The dystonic, they don't have the control, it's dystonic, right? That's why the spiral drawing is like this. Just looking at it. And these are the alert features. If a tremor with any disabling tremor related to the social handicap, rapid increase in tremor, severity or disability, and the presence of any neurological sign other than tremor, look for signs. That means Parkinson's, cerebellar disease, dystonia, neuropathy, all these things. You have to look for those things, and development of symptoms or signs suggestive of systemic illness. So now I would like to go through a few of the things, the clinical presentations. Essential tremors, which are very common ones, which is why I have chosen few of these. The most common neurologic disorder that affects postural or action tremors with a low amplitude and high frequency, as I described earlier. The worldwide estimated prevalence is up to 5% of the population. Family history can be found in near 50% of cases, and in this form is referred as familial tremor, and it is autosomal dominant. And age of onset is variable. That's why I said, in the history, better check what is the age of onset. The upper arms, upper limbs are often symmetrically involved. And in cases of asymmetric essential tremor, the tremor was more severe in the non-dominant arm. Remember it. And it can also affect the head and voice, and uncommonly the face, leg, and trunk. Essential tremor becomes apparent in arms when they hold outstretched, and it typically increases at the end of the goal-directed movements, as actually I described, and amplitude tends to increase with age, while frequency tends decreases with age. Amplitude tends increase with age, and frequency tends decrease with age. And some patients with essential tremor develop enhanced physiologic tremor due to anxiety or other adrenergic mechanisms, thereby aggravating the underlying tremor. Essential tremor is usually relieved by small amounts of alcohol. It's a good news for you all. But in contrast with physiologic tremor, it is not usually aggravated by caffeine, right? And these are core criteria to diagnose essential tremor. So there should be bilateral action tremor of hands and forearms, absence of other neurological signs, may have isolated head tremor with no signs of dystonia. These are the secondary criteria: more than 3 years of duration, positive family history of approximately 50%. How do you manage those patients? These are non-medical therapy as well. Apply wrist waist. We can give some kind of weights to wrists. And non-medical relaxation techniques, we have to teach these people, and eliminating or minimizing use of medication known to make tremors. That's why you have to go through the drug list and check what are the medications he's taking, and avoiding dietary stimulants such as caffeine. And the medical therapy, the first line is the propranolol and the Actually, you know all this, and the second line therapy, of course, gabapentin, pregabalin, topiramate, benzodiazepines, and third line, so we have clozapine as well. So there's interventional therapy for patients who fails pharmacologic treatment with about drugs or are unable to tolerate the side effects. Surgical option including deep brain stimulation, those of course we have. Few seconds. The Parkinson's disease, give me a few, because it's 25, it says. Parkinson's disease, the chest tremor is a hallmark of the disease. I must only talk about the tremor. Tremor fluctuates in intensity and increases with mental effort. The tremor usually becomes bilateral several years after the onset of disease. Moderately severe postural tremor is seen in half of all patients. Rarely, a patient may have postural tremor without chest tremor. That's why I want to talk about these things. And diagnosis of Parkinson's disease is based on the cardinal manifestation, like, tremor, rigor, and the bradykinesia. And the levodopa usually treatment of choice. And there are anticholinergic medications and dopamine agonists also we can use. And the psychogenic tremor I would like to talk about, a peculiar type of tremor that does not seem to fit into any of the known tremor syndromes. The psychogenic tremor is often not rhythmic and tends to be assumed the frequency of voluntary tapping movements performed simultaneously with another limb. And bilateral psychogenic tremor, the limbs often tremble in synchrony. This does not occur in Parkinson's disease or essential tremor. Keep that in your mind. Diagnostic clues include sudden onset, spontaneous remission, and distractibility. So it's your turn to how to do that. And patients with suspected psychogenic tremor must undergo an extensive diagnostic evaluation to rule out other possible somatic causes, including Wilson's disease, dystonia, and epileptic myoclonus. I will talk about only this, the orthostatic tremor, which I come across a lot of patients with, when we don't know it is orthostatic tremor. The primary, we say POT, primary orthostatic tremor, appears on standing and is associated with an intense and disabling sense of unsteadiness, a fear of falling, discomfort, dizziness, shaking, trembling sensation, or some kind of trembling sensation in the limbs or trunk. Symptoms during stance are reduced, abolished by walking, support, sitting, and lying down. And patients are often shuffle, wobble, or seek support when standing. Prevalent signs during stance and walking are bent knees, hem sign, and like broad-based support. And tandem gait may be abnormal. The tremor severity disability scale OT10 is online available to you to check whether it's orthostatic tremor. And so these are the effective medications, include benzodiazepine, clozapine, gabapentin. There are surgical treatments as well. And can I check this one for the dystonic tremor? This tremor can occur in any part of the affected by dystonia. For that, I would talk about dystonia is defined by involuntary maintained contraction of agonist and antagonist muscles. These muscles contract, result in abnormal muscle movements and body postures, making it difficult for individuals to control their movements. It is painful, right? So when they get this dystonia, it's very painful. In those instances, they get these tremors. So dystonic tremor is often jerky, irregular, and variable depending on posture and activity, and may be particularly disabling when the upper limbs are involved. I think I have to stop. There are a few things I have to actually talk about, several things, investigations and key points. Ultimately, this is a reference, and most importantly for the PGs, I have a lot of questions, and when we have time, I will discuss all this with you all. Right, okay, thank you very much.
Many thanks, Dr. Lalanta. Very kind, informative lecture. I hope you have taken us to our old medical school era with this lecture. Now, time to question.
The organizing committee has this, I think, the lecture. If you want, you can ask, because all the questions are also there. You can ask for the lecture.
Thank you very much, and that was Dr. Lalanta Senaratne talking about shaking hands in the silver years, and with great pleasure I invite the chairpersons, Dr. Clement Pereira and Dr. Hiranthini De Silva, to give away the token of appreciation to Dr. Lalanta Senaratne. Thank you very much, and once again handing over the proceedings to the chairpersons.
I now invite our third speaker for this symposium, Dr. Chamara Jayatunga. He will be talking on navigating rehabilitation challenges for community-based recovery. So it is my pleasure to introduce our speaker, Dr. Chamara Jayatunga, consultant in rehabilitation medicine at the Rheumatology and Rehabilitation Hospital, Ragama, the largest rehabilitation hospital in Sri Lanka. He has specialized in rehabilitation with international experience in neurorehabilitation in the UK and is also a diplomate member of the Faculty of Sports and Exercise Medicine, UK. Beyond clinical work, he serves in leadership roles with the Sri Lanka Medical Association Expert Committee on Rehabilitation, the College of Specialists in Rheumatology and Rehabilitation, and the Sri Lanka Association of Geriatric Medicine.
Good afternoon, ladies and gentlemen. Thank you very much for this opportunity and for the invitation. And it's a great pleasure to talk to you today on navigating rehabilitation. And I will focus on the concepts of rehabilitation, as well as some challenges and some suggestions to go forward. So let me share some concerning facts about our population. So 12.3% of the population is age 60 older at the moment, and it's increasingly increasing. And in just 15 years, the idea is that more than 1 in 4 will be over 60. And stroke burden is also rising. And of course, I haven't included here, we all would agree that road traffic accident and related disability is also increasingly getting worse. So some concerns are there related to those facts. So this is the definition of rehabilitation according to WHO. It's a set of interventions designed to optimize functioning, that is one key word, and to reduce disability in an individual with any health condition. And this is the second important fact, in interactions with their environment. That means by definition, rehabilitation has to be individualized. Even though the concepts are the same, there has to be some individualization happening to give or to achieve optimum results. And the primary purpose of rehab, of course, we try to get the maximum possible improvement, but sometimes given the physiological limits, we will not be. Then the goal becomes to function at the highest possible level, despite impairments. And then it includes vast array of interventions, which I will just try to introduce you to at the latter part of the talk. And then this is also a very important point. The mouse. Across the continuum of care. That means rehab does not, or it's not limited to the rehabilitation hospital. Let me explain in another slide. So WHO is very keen to develop rehab services across the globe. And there's this decade. This decade has been chosen as Rehabilitation 2030 initiative. And WHO is saying rehab should be available to all the population through all stages of life, from children with birth injuries or with congenital malformations to kids to young adults, elderly. There's a bit of overlap between palliation and rehab as well. So it goes across our life course. And it should be integrated into all level of healthcare, from pre-hospital to acute hospital to intensive care to subacute, then back to the community. That's what I meant by the continuum. And it's an essential health service. And WHO estimates globally 1 in 3 would need some sort of rehab. That means visual impairment, hearing, mobility, dementias, joint-related problems, neurological, could be cancer, multiple medical problems. So many conditions will need a bit of rehab. And as we discussed, it's only going to increase in the coming years. So this is one of the important slides that I thought I should share with you. So this is the continuum of care in a person with disability. So the patient, for example, you can think of perhaps the bus accident or any medical emergency. So the patient is in the community. There should be pre-hospital services. It's relatively okay in Sri Lanka in most of the areas. And then the patient will go to the acute hospital. There will be some rehab happening in acute medical wards, acute surgical wards, ICUs. That is the rehab in-reach service. From the rehab hospital, the rehab team can visit and give certain extra inputs, but somewhat happening to a good extent in most of the hospitals. And then most of patients will get better and they will be discharged home. They'll go back to the community. If there are residual problems, then the patient will need further rehab. Then we have these three terms I have adapted from the latest Sri Lankan national guidelines, which was published last year. So we have specialized rehab hospitals, which is where I work at the moment, the Ragama Rehab Hospital. We have one in Kandy, Gaul. We have in North Central in Polonnaruwa, Ampara, Jaffna, Mankulam, so Kurunagala. So we have certain designated rehab hospital for a certain set of patients. And then we should have hospitals with rehab units, like all these tertiary hospitals should have their own rehab units, maybe not to keep the patients as much as we would keep in a specialized hospital, but for example, we see patients who are on tracheostomies, a little bit of oxygen, where the patient would benefit from staying in a big hospital where the other specialists are available. And then there should be hospitals with rehab services, like perhaps base hospitals and primary care hospitals. And then the patient will go back to the community, and then we need these services. So community medical, community nursing, community therapy, community-based rehab is a different concept. Long-term care facilities like nursing homes, so we don't have a government pathway at the moment. So that is something to work on over the next few years. Social services, we have certain established pathways. I will introduce you to them. And then vocational services for working age people. So that's the continuum of care. So we have good positive things. Don't take it as a very negative, bleak thing. But there are certain things to improve as well. So current situation of rehab services in Sri Lanka. So we have a long documented history, and if you go to the interest of history, there are records of hospitals built for purpose, people with disability, purpose-built hospitals. And in recent history, so we have these legislations already in place. You can just Google, all these documents are available, which are very good, right? And we have this national guideline for rehab services, which was published last year, October. From a clinical point of view, current services are actually, even though we have that frameworks in the ground level, it is basically still based on hospital level. It's for designated rehab hospitals deliver good rehab services with MDT inputs, but still we have limitations. In most other hospitals, it's mainly as a supplementary service to unwell patients. And outpatient-based therapy are available in tertiary and base hospitals, but again, I think predominantly it's physio, and of course we have occupational and speech therapy, but predominantly physio. So lack of trained caregivers and lack of facilities for patients with disabilities needing long-term, like nursing home level, we don't have pathways, and certain benefits and services are available for social services department. So this is a document that we have used in Ragama. So if you go to that numbered list there, so that's the amount of services that Sri Lanka at the moment is giving to patients with disabilities. So, but we don't have this form available in all the hospitals, but the way to do it is this budget comes from Department of Social Services, it's not the Department of Health. So what I would like to suggest to you is if you see a patient with disability, you can tell the family to go to their corresponding divisional secretariat office, and there's a social services officer allocated or appointed to all these divisional secretariat offices, and they can, that's what I am doing. So I ask the family to ask for those form set, and then any doctor can sign it. You don't need the consultant's signature for all the, your certificate, for all the matters that you certify, but if your consultant is available, you can get the counter signature, but you can just hand it back to the patient. Unfortunately, it's up to the patient to go it and take it back and follow it up. We don't have time for those, but you can ask them to bring the forms. There are considerable amount of funding available, so that's one suggestion. So few slides on a bit of clinical things, how to do the rehab service, or how we do the rehabilitation in a patient with disability. So generally, I would like to suggest this 5-step approach. Identifying the disability, we do detailed assessments, goal planning, outcome measures, and treatment. So there's an old saying, I think, we'll be seeing complex patients as a rehab physicians or as the rehab MDT. Therefore, when the problem is very complex, we try to kind of divide it into small segments or sections. So that's what I mean by identifying the disability. This is the key. If we have identified the problems, then maybe half of the solution is already there. So we use the WHO International Classification of Functioning, which is based on biopsychosocial model, which is very simple and which divides the problem into 5 main domains. So let's take a stroke patient and try to apply that model. So let's say right-sided ICH. So the affected body structure and function will be, we all can imagine what are the problems. So hemiplegia, upper motor type facial weakness, dysarthria, so the list goes on. And please don't forget the psychological impact and potential medical complications. Because of those, there will be impaired activities like turning in the bed, sitting, sit to stand, self-care, transferring, walking, communication, and then restriction of participation, work, kids, it will be playing, going to school, leisure activities. So any of these, if affected, is a disability. Now we know what are the things we can work on. So perhaps we can do certain interventions to get the weakness sorted, get the dysarthria sorted, maybe bladder, psychological, we can work on those domains. Parallelly, we can work on mobility, self-care, transferring, walking. And if the disability is still persisting, perhaps if the goal is to going back to work, maybe we can help, or we can work with the employer, or if it's a child to go to school, if that's the goal, we can liaise with the principal and make certain arrangements, changes there, so that the person can go back to work or go back to whatever the required thing. So that's the message. It's not all we try, of course. Like for example, if it's a spinal cord injury, T10 cord transection, right? Patient will be paraplegic even in other countries as well. Right? There's no way we can, within physiological limits, we might not be able to get the power back. That's the message. But the rehab is more broader. It's not only working with this impairment of the body structure. We work on these aspects as well. That's why we need a team. It's complex. But again, that depends on, for example, T10 cord transection in same, let's say, 30-year-old male, T10 cord transection in US versus Sri Lanka. Same build, same brain, same spinal cord, same fitness, everything else is the same, but disability is different. That is due to, not the personal, it's the environmental factors. So this is the full picture. So again, we need to work on certain things we can work on these aspects as well. For example, home barriers. So for example, if the office is located in the first floor of a building without the accessibility, so the disability is mainly because of this factor rather than the muscle weakness. So that's how we try to do rehab, right? So when we get this map, it will take some time, not in first instance. Sometimes our patients can't communicate well due to aphasia and language problems, language disorders due to the brain injury. So we might have to give phone calls. We ask from family, notes from the previous hospital. We try to get this map so that we do appropriate referrals and come up with a plan. Personal factors are also important. age, gender, of course, gender for bladder health and reproductive goals, level of motivation, key. We can change those to a certain degree. Insight, very important. We need, what we are trying to achieve is a behavioral change. It is difficult. So we might need psychology, behavioral therapists, and type of personality. For a certain extent, we might be able to change or help with the appropriate clinicians. So it's the same thing. We can apply to any condition. I'm not going to details. So chronic non-specific low back pain, by the way, that is the most disabling condition in the world. It's not the stroke. This is the one. So I apply the same model. Right? We work on those. And always remember, in chronic non-specific low back pain, there are emotional, especially in chronic pains, there's emotional elements, there are somatizations, there are other mental health problems, chronic fatigue, fibromyalgia. Just think about those diagnoses as well. Diagnosis is the key in a complex patient. Without diagnosis, symptom-based rehab not going to be very productive. So Parkinson's we can use, can apply. 75-year-old with multiple comorbidities coming with sepsis. It's the same thing, right? Right, okay, so we identify the problems and then we do detailed assessments for the selected problem, right? So I'm not going into detail, so thorough history, examination, and investigation. Unfortunately, sometimes we can't take history from our patients. Even their yes-no is not reliable due to the aphasias. So we have to go, and they are vulnerable patients. They are elderly, they are having other organ involvement, like the brain infection. So our threshold for treatment and investigation is low. And then goal planning, very important. That's the essential component, right? And first thing is to ask the patient what you want. It's not what in ethical practice, it's not what your spouse or your daughter who lives in Canada, in Australia wants. It's what the patient wants. And there are side effects or complications of rehab or therapy. Anybody who can think of what can be the complications or side effects of therapy or exercises? They can get injuries. They're frustrated. It's not very easy, right? It's painful. Freely available services doesn't mean every patient should be, and they can get cardiac problems. After an injury, generally we rest. After infection, if we get fever or like flu, we used to rest. We don't do exercises, right? So these patients get aspiration pneumonia after stroke. We shouldn't subject them to exercises unnecessarily or without any clinical, or without any scientific indication, right? So we have to ask the patient. Sometimes patient make maybe not the most wise decision, but is autonomy. Rejection of treatment is autonomy if the patient has the mental capacity. So that's one of the very important steps. We ask the patient. Sometimes the patient, we might think the arm is the main problem. Patient might say, no, it's my walking and my balance and my ADLs is what I want. Sometimes I say, no, I want to return to driving. So we try to ask, what do you want? And then we set the goal depending on the motivation, the scientific background, and the natural history of the disease. Of course, we get inputs from the family, but it's more deeper than that. So this is SMART, which is acronym for any goal, even for personal goals, but we use it in rehab as well. It has to be specific, measurable, achievable, realistic, and timed. And you can't set SMART goals without a diagnosis. So shoulder pain, can't set SMART goals. We have to know shoulder pain due to what? Tissue capsulitis, impingement, rotator cuff tear, referred frame from neck. Same with the back pain, same with the walking, right? And expected time to achieve a goal depends on the experience as well as the scientific background. Some goals that we set for an elderly patient during early stage of rehab. And so we can't put time for all the patients. So we try to put a time, because without a time, it's like preparing for an exam. If you don't know when to be prepared, our studying might not be very effective. So for rehab also, we try to set a goal. Right? Okay, we'll try to achieve your standing or walking, let's say, by 3 weeks, 2 weeks. Right? Then we can work towards it. We can be a bit flexible, but free hospital bed doesn't mean the patient should be there till, then it's not specific. Right? So we try to put, not everybody will be happy, but careful history taking, examination, and after you develop the rapport, usually it's very easy to agree. It's like, discussing a business plan. So certain things that we do to preserve passive joint range of motion, to preserve muscle mass, do so many things, and to be able to sit in a chair for 60 minutes by 1 week for a disabled person, it's a complex one. So there are small steps in it. Patient has to be medically stable, pain has to be controlled, postural balance, hypertension. We need people, chairs, so not easy. So then we do goal attainment scale to check whether the goal is achieved. And then outcome measures. So we set the goal, let's say the goal is for mobility, then there are so many things you can use depending on your time and how many patients you are seeing in a day. And if you want to do, there are disease-related outcome measures like for stroke, spinal cord injury, and for pediatric, or there's this database, you can just get any outcome measure. Simple things like visual analog scale, the time taken to put on your t-shirt or your uniform for an arm rehab, the time taken to get out of the bed and walk to the toilet in the morning. So I try to use those simple things. So very productive and good to see the improvements. So last step is the rehab interventions. And so we need a team because the problems are complex. So those are the people in the team, patient and the family in the middle. We have these teams running for various complex medical conditions. Now this is for rehab, so there's no hierarchy here. Depending on the patient's need, somebody will see more or spend more time, right? And when the patient is medically unwell, then maybe the doctors will spend more time. But for example, in sports injuries and in certain, fit and well patients, maybe the doctors might not have to spend more time. Maybe the therapy teams who are looking after more. But all the team, and in rehab, since we see complex patients, we get help from all the other specialists, right, when needed, and there should be nice handing over. For example, if you're discharging a patient from intensive rehab to the community, maybe we can do a nice handover of care from a rehab consultant to the consultant family physician, or to the neurologist or whoever who will be seeing the patient. Because a teamwork has a lot of good things, but it has its own challenges, so there should be somebody accountable. And that's generally depending on the decision and the level of care that you're delivering, there should be somebody accountable or a team leader. Otherwise, if the goals are met, no problem. If the goals are not met, there should be somebody to be accountable, especially for medical legal things and complex clinical decisions, right? Best interest decisions when the patient can't give consent, right? So it's teamwork is good, but yeah, there should be somebody accountable and to give the leadership. So when to start rehab? Generally as soon as the patient is stable. So options we discuss. So there can be inward rehab, there can be inward rehab as an intensive rehab or as a slow stream, which is not available yet in government service. Slow stream in the sense that we might do like 1 to 1.5 hours of total time divided into 3 sessions. Intensive means total 3 hours. 2 to 3, that's a big amount, right? Difficult to do. And then rehab as an outpatient, we have it. Home-based rehab, only in private sector, we don't have it in the government. And then these are the criteria to admit to inpatient rehab. So the more impaired patient, stable, fit, and nice clear goals, and patient's consent. Very important, patient's consent. If the patient can't give consent due to the neurological insult, we go into best interest discussion. So 2 consultants agreeing and the family being happy with it. That's how we make the decision. So if the patient does not fulfill the criteria, if the disability less than that, outpatient rehab, otherwise we will review. Few concepts of rehab, interested? So earlier it was mainly, compensatory sort of approach. If the patient has, let's say, right-sided weakness, we might teach them quickly with the left arm to use it as a, the main arm. But here, now we try to use the neuroplasticity and try to get the true recovery. That is, get the functions of the affected limb. It all depends on what the patient needs. Sometimes they might say, no, I want to return to work quickly. So we might have to go for a bit of an early compensatory as well. It all patient-specific. So neuroplasticity is that, like other organs, brain has its own bit of healing and changing ability, so we try to maximize it. This is from Cambridge data, so this is for stroke. The recovery or the true recovery is largest in the early stages. So first 3 to 6 months, very important. After that, it plateaus, but still, depending on the goal you set, still there is evidence that high dose, high intensity rehab can help even in chronic stages of stroke as well. But I would encourage you to refer, if you see somebody being missed in the system, lost in the referral pathway, refer for rehab, intensive rehab. So key factors for brain recovery, are very simple things you can, anyway, I think this presentation will be available on your website. So some messages that as a rehab physician I would like to share with you as family physicians. So we discussed most of these things. So identifying the patient's main concern, that will cut short, I always ask this, that will cut short my consultation time because that's what I'm supposed to do, right? And then setting smart goals in accordance with patient's wish. Pain management, we have good pain services in Sri Lanka, so please ask, are you in pain? Mental health, we have good services, just ask. Bladder and bowel, yep. Remember, sometimes if you ask a disabled person, what's your main concerns, they might say bladder and bowel as the number one, maybe not the mobility. So just ask, we have good options here in Sri Lanka. Referring to rehab team, if indicated, referring to speech and language therapists for swallowing assessment for all these high-risk patients you might be seeing. And then screening for cognitive impairments, can do a MOCA if you have some time. And checking for reversible causes of disability, please. Very important. Right? Rehab is costly, takes time. It's 4,500. At the moment, the government is not giving carers. So it's by mutual understanding, we get the help. We get a carer from the patient party. It's 4,500 per day. The patient is staying in rehab for 1 month. Yep, we're looking at more than 100,000, right? Only for the carer. Yes, there are no carers given from the. We have a lot of good things happening or receiving from the Ministry of Health. We get antibiotics, we get oxygen, we get surgeries, we get good medicines, right? But the care is not yet. Yeah, we are discussing how to move forward, but no, it's mutual understanding. And so we always try to see for reversible causes like hyponatremia, right? Some recurrence of the primary disease. Sometimes tumors, I get for rehab, the tumor has recurred, so there's no point in just wasting time with exercises. So always we repeat, and we get very good support from all these other specialists for those, right? So if the goal is not met, this could be one reason. Right? So current challenges, just 2 more minutes. Current challenges in rehab service in Sri Lanka, I have listed out. I'm sure you can think of what are the problems, right? So I'm not going into all these. Certain challenges, so establishing a national institute of rehab. These have been presented from our college to ministry as well. And then developing current designated rehab hospitals further, and then small designated rehab units in all the tertiary hospitals, and then hospitals with rehab units, that is like base hospitals and the other primary care units. Community-based rehab. This is something I adapted from one of the UK guidelines for rehab service development, somewhat similar. And our health system is very similar to UK, so we can use that. Caregiver issue is a concern. So I've listed some potential solutions as well. We don't have a consensus yet. So establishing pathways, essential rehabilitative medicines, devices. Oh, that's also important. We do get all the medicines and surgical consult, but we don't get the rehab and mobility equipment yet for all the patients with disability. So it's the Department of Social Services which is providing, not the Ministry of Health. So that's why I mentioned get the form set. You can ask the patient to bring the form set and certify. And these are the certain difficulties. So suggestions include policy and system level actions, workforce training, service delivery technology. So can do a lot of small things to see very good results. So we are parallelly working on all these aspects, and incorporating these concepts of rehab into medical and nursing training is also important. And certain practical steps that we are trying to do as a short-term measure. And that brings you the summary. And rehab is an essential component in any health service, and the need is always increasing with the changes in demography of the population. And it should be always individualized. It takes time for the consultation, but otherwise the goals will not be met. And SMART goals, it's a continuum of care, and as as family physicians, there's a big role to these people with disabilities will depend on family physicians for continuation of their rehab. So we will later have a discussion how we can collaborate, because my role as a rehab physician or as a consultant in rehabilitation medicine may be mainly for the perhaps intensive phase, maybe subacute, given the workload and the time taken for these patient care. I think we can perhaps share certain roles between community and the hospital setup, because and also we can it's best delivered with inputs from MDT. Perhaps in future we can have community rehab MDTs, which can be run or led by a consultant family physician or some other consultant who's in the community. Maybe with some, I can join perhaps as a MDT member rather than the team leader. It all depends on the patient's need. We can nicely select. There are nice validated ways to select or put a number and kind of separate the patients, whether this patient can be managed in a hospital or as an outpatient or in the community. So it's all established. So it's a matter of adapting. It's positive way, it's doable. And yeah, we have certain established pathways. It's not very negative, but certain challenges as well. So hopefully in the next few years we can improve it further and increase the rehab services. Thank you so much for your attention. And I would like to thank my teachers and my patients. They're teaching a lot to me. All right.
Thank you, Dr. Chamra, for that practical approach to community rehabilitation. I think due to interest of time, we may not be able to accommodate questions. Just one question.
Thank you very much for your lovely presentation. My question is, what are the minimum requirements for have a rehab unit in a base hospital, including the manpower?
Well, it depends on what's the patient population and what type of patients.
Yeah, I'm asking in a base hospital.
Yeah, no, I mean, what sort of patients we are going to kind of cater. So
okay.
if it's neurological, again, what sort of patients? Are we looking at kind of a step down sort of a patient, or are we going to see more disabled? So it's, I can't give a exact number.
It depends on
on what we agree on.
Yep.
But if we are going to do like, let's say, step down.
It may be a step down, should be a step down, I suppose.
I think then sometimes you don't even need a consultant. Because that patient, if coming to that level, will be seen by so many consultants from ETU to medicine, neurology, maybe rehab, ICU. If it's nice, like a fit and well patient, you don't need, you just need perhaps a doctor and some therapy inputs.
Yeah, that's it. Like the
it
other.
It all depends on how we're gonna start the service.
Yeah.
Yeah, so we can start with very basic.
I'm not talking about the doctors, the other manpower I'm talking.
So yeah, so we will need physiotherapy.
Yeah.
Definitely. We will need, better to have occupational therapies as well.
So those are the questions. At the moment, there are, not enough physiotherapists or occupational therapists in base hospitals. That's the problem. That's what I'm asking.
Yes, so one way to perhaps mitigate is we can, but these base hospitals, when they have ICUs, they have?
Yes, I'm talking about the Homagam hospital, the base hospital.
So
we have only just one physiotherapist at the moment.
Yeah,
that's the problem.
Workforce, I mentioned it there as well. So workforce is a problem. Yeah, but we all work within limitations. So if there's no funding for recruitment.
A lot of issues, I know.
Yeah.
Okay, thank you.
Dr. Chamara, one question for you. In old age, the sarcopenia is the main reason for that recurrent falls and the reduced mobility. What is your message to the family physicians to anticipate prior to delay that sarcopenia, that means the recurrent falls and the reduce, that means slow the morbidity in population?
I think, so sarcopenia, you might not be able to kind of, completely prevent it. So we can go with a very, like a basic approach, maybe without nutrition, maybe strengthening exercises, and then treat whether there's any other kind of a aggravating factor, right? The appetite, they might be having a bit of dysphagia due to some other, neurological condition. So that sort of approach is what I would like to suggest. Bit of flexibility exercises, strengthening, bit of cardio exercises, diet, and reversible causes and drugs and that sort of a thing.
Thank you.
You can do group therapy that works very well in geriatric population.
Thank you again. So we will conclude Symposium 3, and thank you, Dr. Chamara, again.
All right, that concludes our Symposium 3, and that was Dr. Chamara B. Jayatunga, consultant in Rehabilitation Medicine, Dermatology and Rehabilitation Hospital, Ragama. So I invite our chairpersons, Dr. Clement Pereira and Dr. Hirantini De Silva, to give away the token of appreciation to our speaker. Thank you very much. And ladies and gentlemen, with that we conclude the first half of the day, and we are breaking for lunch, and kindly requesting all of you to be back in half an hour's time because we are off schedule. So kindly requesting all of you to be here by 2:20 as we will be having our main sponsor's message as well. Thank you very much. Do enjoy your lunch.